Good morning, everybody. I would like to welcome you on our lecture day. It's a pleasure that we are here together. And we are going to start with the lectures. Professor Giovanni Corona and Professor Mikkel Fode, they will lead our lectures and our conference. And I hope it will be a good scientific day for you. Please start.
Thank you. Thank you, and thanks again to IBSA for supporting this amazing event. After a fantastic dinner of yesterday, now we are moving to the scientific part of the session. So there will be an outstanding faculty with a couple of colleagues from Poland, and also, as I said yesterday, top speaker from the European Society for Sexual Medicine. I'd like to invite you to make questions, so each discussion will be at the end of each presentation, so please don't be shy and ask questions. Mikkel.
And also for me, thank you very much to IBSA, and thank you to all of you for being here. It really is a pleasure to be sitting up here. It's also for me a pleasure to introduce the first speaker, which is our ESSM president, Giovanni Corona, who you already heard talk. And he's going to give us an overview of sexual dysfunction in men and women at different ages.
So thank you, Mikkel. The first talk that we decide to cover is the possible modification of sexual function and dysfunction according to aging. So it is well known that as a function of aging, there is a reduction of corpora cavernosa elasticity, so a reduction of penile sensitivity. And we need to be aware when discussing with our couple that achieving and maintaining an erection should be more dependent on direct physical stimulation. There is also a reduction of plateau phases, a reduction of the duration of orgasm, and as expected, an increase of the length of the refractory period. So essentially, the sexual response curve is moved to the right. What about women? Essentially, there are physiological modification, again, a reduction and delay of vaginal vasocongestions, because you know that essentially it is a vascular phenomenon. There is also an increase of the plateau phase. Conversely, the orgasm response more or less is the same, and there is also no modification of the length of refractory period. So these modifications are physiological modification. We are not talking about dysfunction, problems with hormones and so on, just physiological modification. So again, there is a movement to the right of the sexual response cycle, but at less extent when compared to men. What about the sexual behavior according to aging? This is one of the most huge study, including more than 25,000 people worldwide. As you can see, as expected, there is a reduction of people who declare to remain sexually active according to age, but men who declare to remain sexually active is higher when compared to women. But look at this, only very few, despite this modification, only very few people declare that they no longer want sex. This is very important. Moving to the US, similar results. Again, a reduction according to aging, but people, so men declaring to remain sexually active, the prevalence is quite higher when compared to women. So aging is essentially characterized by an impairment of sexual function, but men remain more frequently sexually active when compared to women. When we look at the possible modification during the last 20 years. These are data coming from Sweden, so Swedish people older than 70. Look at these three different waves, 71, 72, 76, 77, and 2000. So men and women, positive attitude towards sexuality at old age. So this was higher in men when compared to women in 71, 72, but this was more or less the same in 2000. So the situation has started to change. This is another very important study published in Lancet, again 3 waves, 1991, 1999, 2001, and 2010 and 2012. Huge number of men and women, and again, some modification. Look at declare sexual partner of opposite sex, just numbers. First wave, which was significantly lower in women when compared to men. This was not the case in the third wave. Sexual practice with partners. So any sexual experience or contact with the partners, again, if you look at women at the third wave, this was not the same as when compared to the first wave, when compared to men. Again, any sexual experience with general contact with partners of the same sex and at least one sexual partner of the same sex in the past 5 years. So again, no comparisons, so improvement of all these aspects in women in the third wave. And finally, not exclusive sexual in marriage, again, male same-sex partnerships and female same-sex partnerships. So again, modification according to the wave of analysis. So attitudes and behaviors have changed during the last 50 years. I think this is a very old study, but very, very important, based on men in a Dutch municipality near Rotterdam. And as expected, look at this, the prevalence of men reported to remain sexually active decreased from 96% aged 50-54 and 69, 1778. But despite, as you can see, no erection possible, so the black bar increased as a function of age, almost even in the last, so there is no possibility to have a pointer, but anyway, that's fine. So in the last age group, 70-78, more or less 50% of the people, despite not having a normal erection, declared to remain sexually active. So it means that normal erection are not an absolute prerequisite to remain sexually active. This is the European Malaysian study, a huge population-based study, including more than 3,400 men enrolled from 8 European centers. And as you can see, again, the prevalence of moderate to severe erectile dysfunction increased as a function of age. But look at this, the prevalence of people declared to think about sex more than one time per week, around 50% in people aged 70 or older. Sexual intercourse more than one time per week, around 40%. Petting more than time per week, around 40%, as well as masturbation around 10%. So again, with advancing age, normal erection are not an absolute prerequisite to remain sexually active. Accordingly, ED concern increased, peaking 50-59 and decreasing thereafter. So the perception of and the importance of ED seems to diminish among the older men. What about women? Similar results. This is paper published in Israel. More than 120 women aged older than 45 years old. Most common current sexual activity was not sexual intercourse, but breastfeeding, genital stroked, kissing, and so on. Accordingly, again, although the dissatisfaction with sexual life increased, peaking at 50 years old, then decreasing thereafter, so either in men or in women, and the same was the worried about sexual life. So with advanced age, coital intercourse is not an absolute prerequisite for women to remain sexually active. How to maintain a good sexual activity? Women are, clever than men, because look at this, life expectancy in women is larger than men, but theoretically, sexually active life expectancy is, as analyzing the evidence that I already shown to you, so the sexually active life expectancy is larger in men, but men used to lose many years due to a reduced life expectancy. Why? Because essentially ED shared several traditional cardiovascular risk factors. Look at this. These are the data coming from several meta-analyses. So smoking, even the past smoker, was a risk factor for ED, as well as alcohol intake, cannabis use, reduced physical activity, as well as arterial hypertension, diabetes mellitus, obesity, dyslipidemia, and metabolic syndrome. So the reduced life expectancy due to forthcoming cardiovascular disease observed in men is also a risk factor for erectile dysfunction and for reduction of not only sexual life, but also overall general health. Another issue that we need to consider is the frailty status. These are again men and women. Look at this dysfunction and changes according to frail men, pre-frail, obviously there is an increase of sexual dysfunction. Another well-expected issue is the temporal association between deterioration in sexual function and cognitive function again, unadjusted risk, age-adjusted, and also multivariated adjusted. Look at the erectile dysfunction, but also sexual inactivity, as expected, obviously decreased as a function of deterioration of cognitive function. So I'm from Italy. For sure, the cornerstone for a successful aging is what Cicero told us several years ago, a combination of both physical and mental adequate lifestyle behaviors. What do patients seeking medical care for sexual dysfunction tell us? I will show you now some data coming from our lab. Since many years ago, we published this structure interview called SIEDI. It is a 13-item structure interview dealing with the three different parameters dealing with the ED, so organic component, relational component, as well as intrapsychic component. So as expected, the organic component increased as a function of age, as derived by scale 1. Even the relational component, mainly due to menopausal problems and so on, increased as a function of age. Conversely, intrapsychic component, as expected, increased, peaking between 40 and 60 and decreasing thereafter. But I want to stress to you that the significance of ED as a sign of forthcoming cardiovascular disease is very important, not at older age, so older than 60, because in this group, the prevalence of associated morbidities can smooth in some way the significance of ED as a marker of general health. Conversely, as you can see, if we have a pathological organic domain in scale 1, so mean score other than 4, there is a higher risk of forthcoming major adverse cardiovascular events in younger people. This is very important to stress. So in these people, we need to emphasize to change lifestyle, to optimize glycometabolic control, cardiovascular disease, and so on. Accordingly, the significance, this is a meta-analysis published in 2013, the significance of ED as a marker of cardiovascular risk decreased as a function of age. But traditional cardiovascular risk factors are not enough. These are data coming again from our group. We look at the incidence of major cardiovascular events in a large number of people seeking medical care for ED. Around 8% of people suffered from cardiovascular events. In the vast majority of the cases was an ischemic heart disease, and 11% were fatal. So, as expected, we also found an association with several traditional cardiovascular risk factors: smoking, history of cardiovascular disease, obesity, hypertension, metabolic risk factor. But very in unexpected way, we found also an association between increased cardiovascular risk and the reported reduction of female sexual desire. So the reduction of the feeling of love within the couple. So by looking at the Kaplan-Meier curves, indeed, we found that when there was a feeling of moderate or severe reduction of partners' sexual desire and love, there was, even after adjustment for the traditional cardiovascular risk factor in a Cox regression analysis, a twofold increase the risk of forthcoming cardiovascular disease. So how to explain this? It is called widow effect. So a decreased male survival following the death of the spouse. These are the results. As you can see, particularly in the middle age, there is an increased risk in the first year after the death of the spouse. This is true for men. Is it true also for women? Absolutely no. Why? Because essentially partner pushes to their partner to reduce risky behavior, to increase healthy behaviors, and to use healthcare service. This is not the case for men. Accordingly, in a further paper, we found that an association between erectile dysfunction and the perception of the reduction of partner sexual desire was associated with later referral to a D clinic, higher risky behavior, smoking and alcohol, leading to probably to the increased risk of cardiovascular diseases. So beside the conventional cardiovascular risk factor, even unconventional cardiovascular risk factor can contribute to AD-associated cardiovascular risk. So the question is making love dangerous or not? This is a very old study I used to show, but very interesting study. More than 22,000 autopsy cases. 0.17% death during coitus, 94% males. In the vast majority of the cases during extramarital affairs. So very important journal, JAMA, 2011, meta-analysis, showing that indeed the sexual activity was associated with an increased risk of myocardial infarction and sudden cardiac death. So how can we manage this? Looking at more deeply at our data, we published in 2013 this paper showing indeed that the higher frequencies of intercourse, the lower risk. This is not the case probably due to more physical activity, probably higher frequencies of sexual intercourse means better couple relationship, so better feeling, and so increased prevalence and of all the behavior that already mentioned to you, so a reduction of wrong style behaviors, increase of positive lifestyle behaviors, and so on. So essentially, better feeling within the couple, having to better cope all the problems within the couples. Accordingly, in the previous meta-analysis showed that the higher physical activity, the lower risk. Finally, in the last part of my talk, I'd like to address some endocrinology, some aspects related to hormones. What about the male part of you? As you know, testosterone declines as a function of aging. And there are several population-based studies showing this aspect. But look at this. In general population, in the vast majority of the cases, testosterone remains within the normal range. So what is the role of testosterone replacement therapy? This is a meta-analysis that we published some years ago by collecting all the placebo-controlled trials, and we found that testosterone was able to improve sexual function, but only when total testosterone at the beginning was below 12 nanomolar per liter, meaning 3.5 nanogram per ml, and testosterone, look at this, is able to improve all aspects of sexual function. This was confirmed in a further meta-analysis, or an update meta-analysis of the same one, published 2 years ago. What about aging people? These are data coming from T trials. T trials are 7 placebo-controlling RCT, published in the US, including around 800 symptomatic hypogonadal men older than 65, total testosterone below 9.4 nanomolar per liter, and treated with testosterone gel up 1 year. And indeed, again, the improvement of all aspects of sexual function. What about people with very, very high cardiovascular risk? These are data coming from the TRAVERSE trials published last year in July in New England Journal of Medicine. This was the first placebo-controlled trials specifically addressing the cardiovascular issue related to TRT, men 45 to 80, total testosterone below 10.4 nanomolar per liter, treated with testosterone gels, but all the people at high cardiovascular risk. Among around more than 5,000 people, more than 1,000 with low libido were also evaluated for sexual function. And they found an improvement of libido after testosterone replacement therapy, but this was not the case for erectile dysfunction. So in people with, as expected, more severe ED, testosterone is not enough. So testosterone is able to improve sexual desire and sexual function in prenatal patients, even in older population and in those with high cardiovascular risk, but no effect in people with high cardiovascular risk related to ED. Accordingly, this is a recommendation coming from the international consultation, emphasized that testosterone significantly contributed to sexual function, and testosterone should be evaluated in all subjects seeking medical care for ED. What about women? These are data showing the results of the modification of several hormones according to some 4 years before the menopause and 3 years after the appearance of the menopause. And as expected, as you can see, there is a reduction of estradiol. Conversely, testosterone did not modify, at least in the first 3 years, because even in women, there is an age-dependent decline of testosterone. This is in a physiological menopause. This is not the case of surgical menopause. So a reduction of estradiol obviously can increase vagina dryness symptoms, peripheral symptoms, and also can be involved in other symptoms related to the menopause, including hot flushes. But for testosterone, there is an age-dependent decline. So what is the role of testosterone in women? The situation is more complicated than men for several reasons. First of all, for considering the current immunoassay are totally unreliable for the evaluation of testosterone levels as we usually see in women. So there is an association between endogenous androgen concentration, but the evidence is still conflicting, and obviously there is no cutoff due to the reason that I already mentioned to you. These are the recommendations coming from the agreement of several societies, and we were in 2019. But Elisa Maseroli from Linda Vignozzi group in Florence in 2025 published this meta-analysis showing indeed that circulating testosterone levels was lower in women with sexual dysfunction. This was also confirmed, excluding women taking oral contraceptive, and also the desired domain was confirmed to be associated with a reduction of testosterone circulating levels. And this was also true when free testosterone levels were evaluated. There is also another meta-analysis published in Journal of Sexual Medicine in 2022 showing that testosterone was able to improve several aspects of sexual functioning in women, including sexual desire. So the agreement nowadays is that testosterone can exert a beneficial effect on sexual function and can increase in subdomain of sexual desire. So a trial can be done, but since the vast majority of the study were performed in women reporting an impairment of sexual function, so the data cannot be generalized, and especially hypoactive sexual desire disorders cannot be generalized to other type of female sexual dysfunction. What about other menopausal symptoms, and what are the recommendations? So this is a flow chart, very useful flow chart. So if there are moderate to severe hot flashes, and there is also the presence of peripheral symptoms, so there is no contraindication for the use of estrogens, we can consider it vaginal estrogens. Conversely, if there are some contraindication, we can consider the use of vaginal lubricants. If there is no moderate or severe hot flashes, because the local effect on the central effect is not so high. If there are symptoms, so moderate to severe hot flashes, and if people are interested to hormonal replacement therapy, we can go ahead, but indeed we need to consider the cardiovascular risk of the women. And women at high cardiovascular risk are those with history of cardiovascular disease, diabetes mellitus, using cardiovascular risk engine, we can in some way calculate the cardiovascular risk in 10 years, so higher than 10%. In this case, we need to emphasize the use of transdermal estradiol as the first-line treatment. Because essentially, transdermal estradiol has not been associated with an increased risk with venous thromboembolism, so does not modify the prothrombotic risk, especially in subjects, in women with prothrombotic mutation. So for sure, we need to move to transdermal estradiol. Another issue is also the use of the type of progesterone. So indeed, progesterone and dihydrogesterone have a neutral effect on coagulation and metabolic parameters. So we need to emphasize the use of this kind of parameters in women with an intact uterus for sure. So if there are some contraindication, the suggestion is to use SSRI, or as well as clonidine that can work acting at central levels by reducing hot flashes. And this is a meta-analysis showing you the results. So, estrogen replacement therapy might improve other menopausal symptoms where contraindicated SSRI or clonidil could be useful. My conclusion. As for various other functions, aging is characterized by modification and reduction of the frequencies of sexual activity. Sexuality represents an important issue in aging men and women. There are a number of ageist stereotypes in our community which make it difficult for both doctors and patients to discuss sexuality openly as they become older. The situation often results in sexual issues not being adequately addressed, that resulting in depression, social withdrawal, delayed diagnosis of underlying medical conditions. So information from physicians regarding normal age-related changes in sexuality, together with advice on how to continue meaningful sexual relations, may play a great role in altering such negative attitudes. So for those who were not here yesterday, just to remind you, our school, we have the chair of our school, Kobe Reisman. So go to our website to more information, fantastic educational activity. Who are interested in the female sexual dysfunction, our school related to the use of ultrasound, surgical academy, those who are more interested into the surgical part of the coin. If you want to join the international consultation in Madrid, and obviously I'd like to remind you our Congress in Vienna. Thank you for your attention.
Do we have the microphone up here?
Share this one for now.
Okay. Thank you. So thank you for the excellent talk. And as we were saying to begin with, if there are any questions from the audience, we'd be very happy to take them after each talk as we go along. To start it out a little bit, I could just maybe ask you, you're talking about dying during sex, having a myocardial infarction. There's a new Princeton consensus guidelines where a lot of very smart, especially cardiologists, have been sitting together talking about what should be done before you can treat sexual dysfunction. But on the other hand, we have studies that show that this activity equivalent to sexual dysfunction is a brisk walk. So does it really make sense to tell people that they shouldn't have sex? Shouldn't we tell them they couldn't walk as well?
Yeah. Thank you for these interesting questions. Indeed, there is a very old guidelines coming from the Princeton Consensus Panel saying that indeed if there is an acute event with no complication, you can start to use PD-5 inhibitors after 6 weeks. We had a lot of discussion with testosterone, more or less is the same, but these are recommendations based on very old study. Probably we need to update this one, but for sure, I think that sexual dysfunction, either in men and women, should be a moment, so the occasion to discuss with them the possibility to change life, to modify sexual negative lifestyle behaviors, to improve weight loss, to quit smoking, and so on. So this is my point of view. I don't know if any one of you is involved in hormonal replacement therapy, men and women. Anyone? Please stand up your hands. So any idea or any concern related to the cardiovascular issue of testosterone in men? Here in Poland, do you have either gels and injectable or just gels? Yeah, so any concern?
So, Jan Wolski, in my opinion, is testosterone replacement therapy is very useful for men in older age. And honestly, I should say that I have no observation among my patients that they have myocardial infarction or other cardiovascular events. But of course, before the improving this treatment, I always check with cardiologist looking for the safe of therapy.
Yeah, I agree. I think the main problem were related to especially what happened in the US. You know, in the US, up to 30% of people who were prescribed testosterone were never checked for testosterone levels. Never checked. I'm sad, I'm depressed, I have fatigue. Okay, take testosterone. So this is the main problem related to the issue. And another issue was related to women, when very, very old study published in the beginning of 90 emphasized the possible cardiovascular risk in a wrong population using wrong type of estradiol. So I think we need to manage and to give to our couple and to our patient the correct information. Any other questions? Yeah, please.
As a continuation of what you said right now, it's what I often meet in my clinical practice. There are middle and older age men that are coming and they already received either testosterone or clomiphene, and checking their hormonal levels before, they were once checked, and usually they had testosterone within the range, but in the lower quartile of the normal range. You never know what the whole normal range is also wide, and you don't have a sense what they had like 10 years before and 20 years before. And the clinical question is what to do with these men, whether you would send them back to the physician that had prescribed testosterone and he can or she can care about it, or you give any other advice?
No, for sure. The evidence is that when testosterone levels are above 3.5 nanogram per ml, 350 nanogram per deciliter, or 12 nanomolar per liter, there is not sufficient evidence to emphasize the use of testosterone. But there is another problem, SHBG. SHBG, you know, the common immunoassay are totally unreliable for the evaluation of free testosterone, totally unreliable. So please do not suggest to use free testosterone. The mass spectrometry is still too expensive. So we can use SHBG because SHBG binds around 50% of circulating testosterone levels and can be influenced by several factors, including thyroid dysfunction, including obesity, including aging, and so on. So if including also unexpected chronic hepatitis, or the use of anti-epileptic drugs that can be used also for as mood stabilizers. So if you have an increased level of SHBG, you can overestimate testosterone levels. If you have a reduction, you can underestimate testosterone levels. So my suggestion is to use SHBG and to calculate free testosterone. Yes, please.
Hello, Marcin Radko. We have been discussing the levels of depletion of testosterone levels in aging male. We had also mentioned SHBG, higher levels of estrogen associated with metabolic syndrome, insulin resistance. But I would like to ask you, what is your opinion on of decrease along with age, of the decrease of sensitivity of androgen receptors?
This is another issue. Usually the EMA study, you know, just to give you insight for those who are not aware, there is a polymorphism in the receptor, in the gene codified for the receptor of HBG that essentially can modify the sensitivity of androgens receptor. And obviously we cannot measure this possibility. Essentially, EMA study showed that if the people with a reduction of sensitivity, there is in some way a new setup of the hypothalamus pituitary axis, increasing LHA and normalizing the level of free testosterone. Indeed, I think that this could in some way discussing for a pharmacological point of view when we are using testosterone for sure, but at the present time is 1 million questions, so we cannot address this one. Any other questions? Maybe, I don't know, Kobe, if you want to emphasize the school, just... I will keep it to my... Okay, that's fine. That's fine. So we can move to the other one.
Okay, thank you so much. We move to the next talk. It's Professor Krajewski, who's going to talk to us, another general talk about the importance of a healthy protective GAG layer and urothelium damage.
Dear Chairman, dear colleagues, thank you very much for the kind invitation. Yes, this is more general talk, not directly associated with the sexual function, but in bladder pain syndrome, it's really important. Yeah, let's go for the basics as a starter. So, as you know, the bladder is inside lined with the epithelium, which is called the urothelium, which varies in thickness depending how relaxed or how stretched the bladder is. As this cartoon shows, there is three types of layers. The apical one is, of course, the superficial cells, apical cells, or the umbrella cells. This is only one layer. After that, you've got few rows of intermediate cells, which are not that differentiated and differentiated into the umbrella cells when those apical cells get exfoliated or damaged, and of course the basal cell layer, which is more or less the stromal part. And this is how does the normal bladder look when we prepare it for the histopathological assessment. You can see that urothelium is pretty thin when compared to other parts, and this also can be observed, especially when we perform the transurethral resection with some high energy source as a laser. In this case, we can see that cohesion and color of the tissues of the mucosa, submucosa, and the detrusor muscle is completely different. We all know that for urothelium, the main function is to store the urine and to isolate the tissues and the other tissues from the toxic waste, which is actively secreted into the urine. And of course, the urothelium's got some efferent function, which mainly serves for the communication with close by cells. And what is most important in the subject that we talk about today is the afferent function. The urothelium is gathering information and transmitting that information into central nervous system. Those umbrella cells are not symmetric. The apical part of the upper part of the cell is completely different in terms of membrane buildup. The receptors are different, the proteins are completely different, and when you zoom in the microscopy, you can see that the relaxed bladder is pretty wrinkled because the surface needs to be stretched when the bladder is getting full. And when we focus even more, you can see those nice pictures of those patterns of uroplakins, which are small particles, small proteins, to which the glucosaminoglycan layer is being attached. We all know that the GAG layer is a coating which is watertight, waterproof, is mainly based of hyaluronic acid. It's mainly composed of hyaluronic acid, chondroitin, heparins, and keratins. But everyone says that this is a thick mucous layer, that this is a thick GAG layer. The right answer for that is that this is not that thick. As this cartoon was showing, it's almost 1/10 of one cell depth, so it's not that thick after all. So the main hypothesis is when the GAG layer is damaged, there is an option for bacteria, toxins, and any other things that are diluted in the urine to irritate the urothelium. And when the GAG layer is normal, of course, there is no way for those things to irritate the mucosa. And that was proven in animal model, in the rodent model, in some rats, in which the GAG layer was digested by enzymes. And in urodynamic study, it was shown that there was some decrease in bladder function, and as well in histopathologic assessment, it was shown that apical uroplakin layer was completely damaged. There were increase in infiltration of neutrophils and other cells, increased permeability. And what is very important, when the C-section of the spinal cord section, the spinal cord were assessed, there was increased expression in C-phos-like proteins, which are normally in normal circumstances responsible for pen-like transmission in the spinal cord. As well, it was confirmed in the other study in which authors went one step forward, not only digesting the gag layer, but also giving the additional intravesical installation of gags in some of those rats, showing that even in those animals in which the gag layer was digested, when they gave additional gag intravesically, those symptoms came back to almost normal. So the hypothesis is the gag layer is damaged, there is cell exposure, and diseases and the symptoms of the disease. We also have to remember that urothelium or epithelium of the blood is not only urothelial cells, but also it's infiltrated by nerve endings, and it's full of different receptors. Majority of them are in the group of TRP receptors. Of course, there are various types which are expressed in various places in different amounts, but majority of them are responsible for transmission of the stimuli that can be translated into the pain stimuli. So what can damage the bladder mucosa? Of course, we've got the whole group of infection. We can damage the bladder mucosa with some toxic factors. Example is chemotherapy in the hematological setting, can be post-radiotherapy, can be some autoimmune, and of course some foreign bodies. I know that radiation cystitis will be covered later on, more in the terms of sexual function, but I would like to show some slides about it now as well. So when we irradiate the pelvic area because of any reason, any cancer, of course there is some collateral damage to the bladder, no matter what technology are we using. And it's, after all, we finish up with the acute damage to the bladder, some edema, some damage to the mucosa, damage, of course, to the gag layer, and some damage to the vessels, which after months or years, it's translated into general fibrosis and general damage to the small vessels. And this is how does the bladder after radiotherapy in chronic phase looks like. You can see that the pale fibrotic mucosa with irregular vessels, which are very easy to damage and that bleed very easily after contact. As I said, the next speaker will come into the detail about sexual dysfunction in these patients, but we all know, and this is obvious, that in this patient the problems or the sexual dysfunction is pretty common. At least 50% of patients report dissatisfaction, some decreased libido, decreased desire, and in women it can be divided into two phases. The first one, which is because of damage, acute damage to the mucosas and other epithelial tissues, and the late one because of the fibrotic consequences, and in males it's mainly attributed to the vascular injury. And this is the slide which is copy of which is the photo of our protocol that we use in our university. So that's one is in Polish. In general, in those people, we do not have much things to do to alleviate the symptoms. For those in which those symptoms are not that high, we can just ask them to change the lifestyle, to reduce some dietary of food, some dietary things that can trigger the symptoms, to perform the bladder training, or to use the cholinergics. In other patients, we can of course use the intravesical installations of the gags, or maybe botulinum injections in various doses, or of course in those severe cases, we can perform some more advanced and more invasive proceedings. As we all know, all the cholinergics and mirabagrons got a lot of maybe not toxicity, but side effects that cause that the patient do not tend to take them for a long time. The dropout rate is pretty high, especially after some months. I have found one nice study showing that the botulinum injection in patients with radiation cystitis and BCG cystitis, maybe the study is not super big because only 6 patients were presented with the radiation cystitis and 6 with BCG cystitis. Anyways, those results are pretty obvious. The botulinum injection was effective in reducing the urinary frequency and making the bladder capacity higher. But we have to remember that botulinum as well has got some range of toxicity, the acute urinary retention, infection, and of course hematuria. The one thing that does not have any special toxicities, of course, intravesical installation of GAGs. This is the study in this particular setting in patients after radiotherapy because of the prostate cancer, in which the most important alignment was nicturia. So as you can see on those graphs, after the whole schedule of intravesical installations, the reduction in nicturia was pretty obvious. The same in other studies showing the same population, 30 patients after radiotherapy because of the prostate cancer, assessing not only nicturia but other aspects of lower urinary tract symptoms. And two conclusions can be drawn. One, which is the middle bar in each graph. Each graph is assessing any other aspect of lower urinary tract symptoms. So you can see that the first bar is just before radiotherapy, the second one is just after radiotherapy. So we can just see that after the radiotherapy causes some problems in our patients. And the third bar is just after finishing the schedule of intravesical GAG insertion. So the time plus GAGs can relieve the problems in those patients. And finally, one of the best study in data in this population, randomized, controlled, and prospective, showing that even in longer periods, in longer follow-up, there is symptom improvement and improvement in quality of life in those patients that were irradiated. Of course, the majority of those symptoms are just not that high grade, but in some patients the hemorrhagic cystitis happens, and this is the clinically important and clinically difficult problem to treat. There is a bleeding from whole mucosa, whole irradiated mucosa, in some cases from every single part of the urothelium, causing gross hematuria, tamponade, and even anemization of those patients. And majority of those people are bleeding because of the radiotherapy. Of course, they could be a subject for hematological chemotherapy, but now because of MESNA and other precaution factors, the risk gets lower. Anyways, that's mainly radiotherapy associated. Different authors and different publications show different decision trees how to manage those people. But if you did have any type of those patients, you know that this is very difficult. So what to do? Of course, the first one is to take out the causative factor, which is not always possible. You have to hydrate the patient well to ensure that there is high bladder output. If he or she is anemic, blood transfusion. There is an idea that fluoroquinolones are also active for BK virus, which by itself can be a risk factor for hemorrhagic cystitis. So giving fluoroquinolones in low dosing can help for that. Also, more invasive options include transurethral coagulation with the green laser. The green laser is better in that setting because the green laser light is absorbed by the hemoglobin, not at water as the holmium laser, but if you don't have it, you can use, of course, the holmium laser with the pulse modulation, for example, virtual basket. The hyperbaric chamber works great if given in multiple sessions. However, in our department, for example, those guys do not want to use that treatment in the patients with active neoplasm. We don't know why. There is no literature showing that it's harmful for those patients, but just no. Also, you can give the installation of formalin or alum, but maybe only in Poland. But it's difficult to get those solutions of those things that are proper for this particular patients. So our pharmacy is trying to mix up some things which are available, very difficult. Embolization also is a way to go in some patients, but if you have any experience with interventional radiology, you know that getting into those small vessels is super difficult. And of course, in those patients, completely hopeless, we can perform cystectomy, which is a nightmare in these cases. Off-label, we can, of course, use gags, maybe orally, maybe intravesical. We're not sure what is the best way. There is no data, but for sure we will not harm the patient. The other option is UTIs. Also, I will not cover the sexual aspect of those, as it will be covered later on. We all know that the bacteria attacking the bladder or urothelial tract has got a lot of uropathogenic factors that allow the bacteria to attack the bladder. Some of them are a lot of adhesins, some toxins, and some proteins that, for example, acquire iron ions. On the other hand, the bladder's got the natural defenses, the normal flora, high urea concentration, some proteins which are actively secreted into urine, and some other immune responses. But one of the most important, of course, in normal setting is the gag layer, which prohibits the adherence of the bacteria, and not only Escherichia coli, but all of the bacteria that were tested. That was shown in many studies a long time ago. And when this gag layer is digested, in this case by acid, the adherence level or adherence potency of the bacteria, no matter what the species is, goes skyrocketing. The other nice but harmful mechanism of the bladder to remove the excess of the bacteria is exfoliation of the apical part of the cells. Of course, it's very efficient, as a lot of those bacteria are getting washed out. However, the bladder, the inner parts of the mucosa, is being exposed for some toxins and other harmful particles. We know that UTIs are pretty common, especially in women. In women, at least 50% of women have experienced at least one episode of UTI, and this is not well studied in terms of sexual dysfunction. Even our pro, who is Kurt Nabel, said in a recent article that in an already neglected field of research, the effect of recurrent UTI on sexual function is particularly under research. This is a nice study, old but nice study, analyzing what young women post online about the subject, and the conclusion is relation between sex and UTI led to feelings of disgust and fear related to sex, and women reported substantial negative effect on relationship. And finally, good quality study showing that at least 30% of women experience often or very often urinary tract infections after sexual intercourse, of which 60% state that is severely negatively influencing the quality of life. Of course, we talk now mainly about recurrent uncomplicated infections, and our guidelines give us a lot of options what we can do in those mainly females. Of course, not all of those recommendations are deeply rooted in the evidence. Still, we've got some new nice things. For example, the simple cranberry products that in recent meta-analysis by Cochrane Group showed that it's effective in women with the recurrent UTI. The cranberry products diminish the risk of getting next recurrence. This is, of course, because of the fact that the cranberry products and the man nose, which is the next thing that can be used, and we've got literature for, blocks the adhesins. Each of those block the other type of adhesins in other place of the urinary tract, but still, as the gag layer, those things prevent the bacteria to adhere to the normal mucosa. The next nice study, which was highlighted during this EAU, is a non-inferiority study of hip rate in terms of efficiency in reducing the risk of recurrent urinary tract infection when compared to trimethoprim, and it showed that the hip rate is not inferior to the trimethoprim in this particular indication. Also, estrogens, but given locally, of course, not given orally, but given locally. We've got nice literature, nice meta-analysis confirming that when given locally, it works pretty nice for the recurrence diminishing. The question is if we can use it for the breast cancer survivors, because this is the main fear in physicians. So yes, we can do it. We've got piling evidence showing that in those patients who had breast cancer before or even have now, it's safe. It's safe to use it as a prevention of recurrent tract infection. And of course, we can use intravesical installations of GAC. We've got plenty of literature showing that this is one of the oldest studies on only hyaluronic acid, but you can see, just taking a glimpse on the Kaplan-Meier curves, that the risk of recurrence is much smaller. We've got a nice study in the rodent model, once again, measuring if hyaluronic acid is better than chondroitin sulfate or maybe the mixture. So it seems that the mixture is the best way to reduce the bacterial growth rate, and this translates into the literature that we have. We've got a lot of preclinical studies about it. We've got 2 RCTs and 2 meta-analyses showing that it's in this indication that it's efficient. This is one of the randomized control studies that was published in European Urology 15 years ago on 57 women, that showed that using that installation reduced the time to next UTI episode 3 or 4, even 4 times. You can see on the survival curves that the difference is evident, and that was of course confirmed in meta-analysis. We've got one for 2013. You can see on those forest plots that the difference is evident. The same in the later meta-analysis from 2018. Basically the same result. It works, and therefore the recommendation in the guidelines can be found that intravesical installations of the combination of hyaluronic acid and chondroitin sulfate works. Thanks.
Sorry, do we want to address also the other one? I think we can have the next lecture and then having the discussion at the end of next lecture.
So now let's talk about the thing of which the previous one was the entrance for. I mean the chronic pain in the pelvic area. It's all about the nomenclature. We've got some older or obsolete terms: the bladder pain, interstitial cystitis. In males, that would be prostadynia or prostatitis. We should not use those terms. It's better to use, as some of them, for example, cystitis, suggests some inflammation which is not there in every single patient. So it's better to use the primary, whatever the painful organ is, pain syndrome. So the primary bladder pain syndrome, for example. The epidemiology is very difficult to describe. There are some studies showing that it's very common. There are some studies showing that it's not common at all, that there is some female predominance, but we also not sure if there is a female predominance or just females report that much more commonly. The same applies for men. The range of in studies goes from 2 to 15%. What is obvious is that the problem of chronic pelvic pain syndrome is much more common than what was previously believed. There are a long list of risk factors for that problem. It can be infectious, genetic, neuromuscular, whatever, psychological, of course, and some defects in the glucosaminogen layer. What is interesting, those pain syndromes are related to other the diseases which are psychologically driven, fibromyalgia, irritable bowel syndrome, but also with those which are just simply asthma or allergy. This is the diagnostics of the exclusion. We have to exclude any infection, bacterial, viral, whatever, any malignancy that can take place in the pelvic area, stones in the distal ureter or in the bladder, neurologic disease, problems related to the previous radiotherapy or previous chemotherapy, endometriosis, and new kid on the block who is ketamine uropathy that will come back a bit earlier. As I said before, our guidelines suggest that we should use the name, the proper definition, the proper naming, which is primary pain syndrome, as there is no proven infection, there is no proven other pathology in the region that we are discussing. In our guidelines also we can find some nice tips and tricks and descriptions about every single problem. For example, in the prostate pain syndrome, you can find information that it should be performed the transrectal examination to convincingly reproduce the pain in the region. When we're phenotyping, the pain is mainly located suprapubically, and it goes up, the level of the pain goes up when the bladder is filling, and it's relieved while, during micturition, and it can be aggravated by some certain types of food or beverages. When we perform cystoscopy, the bladder mucosa, the bladder aspect can be completely normal. We can find some glomerulations. We can find that pathognomic oozing from the bladder wall, those waterfall bleeding, and of course, in more severe cases, some tearing of the mucosa and the submucosal layer may be found, which is called the Hane lesions. And our guidelines suggest that we should describe those problems in a way that can be reproduced by other physicians in the typical table. Of course, we should take the biopsy and perform the histopathological assessments of the tissue just to standardize the way that we're describing the pathology in each individual. And we all know that the chronic pains got severe influence on the sexual life. No, it doesn't really matter what type of pain it is. In this particular study, in females, 70% of females with the chronic pelvic pain syndrome reported some degree of sexual dysfunction, in which 30% were very concerned, meaning that those symptoms were pretty severe. Very nice study comparing one group of 100 premenopausal younger women with diagnosed chronic pelvic pain with those 100 healthy controls, and basing on the female sexual function index, the authors showed that those females with chronic pelvic pain presented much worse sexual function when compared to healthy individuals. The same applies for males. A study from China, almost 2,000 patients with diagnosed chronic prostatitis, so primary prostate pain syndrome, showed that at least half of those patients present some degree of sexual dysfunction. Some of them got erectile dysfunction, some of them present the premature ejaculation, some of them both. However, all of those symptoms are related to the duration of the pain, to the level of the pain, and of course, to the age of the patients. When we take a history in those patients, we have to make a deep dive into the last questions that we normally do: frequency, nocturia, urgency, all those questions. We have to ask about the drug that the patient is taking, not only medical drugs, but also the recreational drugs. And we have to ask a bit more psychological questions that we do not normally do. For example, what do you believe or fear is the cause of your pain, or how does the pain affect you emotionally, as not only those problems overlap some psychological problems in vast majority of patients, and also those problems overlap some gynecological, gastrointestinal, peripheral nerve problems. It means that all of those patients should be treated multidisciplinary, especially when other problems arise. When we take a history, it's always good to use some questionnaires which are validated and which are designed for this particular indication, this purpose. And for the bladder pain syndrome, we've got the interstitial cystitis symptom index, which is not translated and validated in Polish, but is there. For sexual assessment, simple sexual assessment, we can use all those simple ones, the cited previously female sexual function index, or the simple one for the erection or premature ejaculation in males. When we examine the patient, as I said before, as many of those people, or all of them, got some psychological driven problems, we have to explain very thoroughly what we'll be doing while examining them, how and what we would like to achieve, and get the informed consent, of course, especially when we perform the transrectal examination or manual examination in females. We can perform a lot of various tests just to exclude the other problems as infection, malignancy, whatever. We perform We perform culturing smears, we perform the tuberculosis testing, STDs. Of course, we can do some more advanced or more invasive tests like cystoscopy, urodynamics, potassium sensitivity test, or cold water sensitivity test, but all those more invasive tests should be performed only in those people in which the results of the test will influence our further decisions, not just to perform the test, but to change our further proceedings. And as said before, our guidelines give us a list of things that we can use, we can employ. However, the level of evidence in majority of them is not, let's call it, not perfect. The recent network meta-analysis showed, analyzing a lot of them, that the efficiency of majority of them is not perfect neither. However, we've got some guidelines, we have to do something. Sorry. So what our guidelines said we have to do, of course, we have to perform therapy which is phenotype oriented. We have to perform multidisciplinary treatment. We can do the dietary exclusions. We can give some antidepressants. We can give GAGs both orally and intravesically. We can perform botulinum injections. We can perform a neuromodulation and some more invasive treatment. But starting with the treatment, we also have to discuss with those patients the expectations and educate and explain to those people that it's mainly not possible to treat them completely. Maybe the real aim should be lowering the symptoms up to the moment, up to the level in which those symptoms will not influence their quality of life that much. We can start, especially in those patients in which some triggering food or beverages have been found. We can start with dietary interventions. It's almost always a good idea to refer the patient for some physical therapy. The problem is you have to find a guy who knows what he or she does during that therapy. You need to find a pro. For that, in the region where I live, we've got one, Kuba Ptaszkowski, he's called, who's got a PhD in this setting, and he's a really magician. The bottom line is not to perform too much exercises that strengthen the pelvic area, because it can even exaggerate the problem. We've got a whole range of pharmacological things to give to our patients. But once again, you have to consult the patient well. You have to talk about the risk factors and the side effects, as it can be pretty stressful for the patients. You can use some simple and more advanced painkillers. You can use amitriptyline as antidepressant, or more potent immunosuppressants, especially in those people with proven inflammation and proven Hane lesion. The first one, or the easiest one, is of course the oral GAG, which is pentosan. There are no maybe high-grade side effects. However, as all of those GAGs it's got some anticoagulant effects, so should not be taken perioperatively, no matter what operation is being performed. And we've got now some case reports stating that there is some retinal toxicity related to the drug. The thing is, it has to be taken for a long time and in high dosage, because it was proven a long time ago, but it was proven that when we administer the drug intravenously, only 10% is being secreted in the active form in the urine, and when we take it orally, only 1%. So therefore, you have to take a lot for a long time. In Poland, the problem is that this drug is not refound or reimbursed for the Polish NHS. It's very difficult to find. It's very expensive to buy. You have to take it from abroad, or some other generic drugs from abroad. Maybe for the Yaluril, there is no as good data showing how much of that compound is being secreted in urine, but extrapolating the results from pentosan, we can try it, especially that the toxic profile is pretty okay. Antidepressants is not always a good idea, but it's not a bad idea to try to refer the patient for the professional who can give it. We always can start with amitriptyline in low dosing. The maximal dosing is 100 milligrams in splitted split it twice daily, you have to remember that it's got some liver toxicity profile and the cardiac toxicity profile, so it's always better to refer the patient to the specialist who has the experience in those drugs. And of course, you have to remember that as any other antidepressant, it's got some influence on sexual function. Majority of those things happen in those patients in which there are some primary affective disorder before. However, in patients without depressive symptoms, also there is some influence. All those more potent immunosuppressants like cyclosporine or steroids, they work pretty nice in advanced cases. However, the complication profile or toxicity profile is pretty nasty, and therefore it should be given by those specialists who know how to deal with those, for example, dermatologists, rheumatologists, or some skilled nephrologists, maybe not urologists. And the one treatment which does not have any additional risk factor or toxicity is intravesical gas installation. In this randomized controlled prospective trial, it was shown that all of the patients received full scheduled installation. It means that all patients were fully compliant, which is not comparable to any other drugs. There are some, of course, contradictions like active tract infection or problems in administering the drug, for example, putting the catheter in, but still it's not a big problem. And in this particular indication, which is chronic bladder pain syndrome, we've got nice literature showing that it works. We've got meta-analysis confirming that it reduces the pain, it reduces all the aspects of aspects analyzed in each questionnaires. It makes the bladder go bigger and the micturition volume go higher. After that meta-analysis, some other prospective studies were printed, mainly showing the same results. The other treatment without any, let's say, high-grade toxicity is shockwave therapy, and especially in males, and especially in those males with prostatic aspect of chronic pain syndrome, and in those with erectile dysfunction. The literature maybe is not super strong, but the one what is there shows nice results, and our clinical experience confirms it. It's a nice treatment. You can perform also some neurological interventions. For the sake of time, I have to skip those. You can perform those interventions on the skin, through the skin. You can implement electrodes into the spine, or you can perform the pudendal nerve blocks if there is some pudendal neuralgia. For the surgical proceedings, as this is much more urological type of things to do, and I would like to go into the smaller details in those. You can perform the distension, botulinum injections, resection of the Hane lesion, and some more advanced proceedings. We can perform the hydrodistension. Everyone does that. Everyone knows that it works, but nobody knows how to do it precisely. There is no precise literature. We don't know for how long, what should be the irrigant, water, saline, glycine, whatever, what pressure should be applied on the bladder, or if only one session is enough, or we should make it or perform it multiple times. As I said, no literature to confirm that. In 2005, there was a nice survey from UK on 244 clinicians, consultants, urologists were asked, and the results are pretty diverse. The time, the pressure, the multiplicity of those sessions were completely different. So we can also give the botulinum injections. This works not only as a, my slide is a bit cut, no worries. It not always cuts the pain, but also improves urodynamics of urodynamic results in those patients. The problem is we're not sure what dosage should we imply, where to inject and how to inject the botulinum, and we have to remember about the risk factors. This study showed that injecting the botulinum in those patients with the bladder pain syndrome is related to much lower risk when compared to patients with overactive bladder. However, the risk is still there. Also, there is a recent study showing that in female patients with bladder pain syndrome and sexual dysfunction, injection of botulinum improves the sexual function. Finally, we've got the resection of the Hana lesion or whatever lesion that we can find during the cystoscopy with the extension. This is, let's say, controversial, as in the gastroenterology, we do not resect the gastric ulcer, rather we treat the underlying pathology, and it seems the same here. There are some results, there are some studies showing that the resection can be efficient. However, the literature is not very strong for that, and we have to remember that any manipulation, transurethral manipulation, can end up in chronic or acute or even chronic sexual dysfunction. Finally, we can perform cystectomy, partial, radical, whatever, but you have to remember that this is the procedure which is related to very high mortality. The risk factor, the risk of complication, of high-grade complication, is really high. So it can be performed only in those places with big experience, at least 50 or 35 yearly, and in those highly selected patients. In our guidelines and in general, let's say, bladder cancer community, there is a trend of performing cystectomy which is sexually sparing. Mainly, of course, the literature that we have or the ideas that we have are based on bladder cancer population. So all the population, so we can, in those people which are still sexually active and would like to preserve it, we can perform the prostate sparing, capsule sparing, or whatever sparing, of course, if the oncological environment allows us to do it. In female, the idea is the same. In some patients, we can perform totally sexual sparing procedure without hampering the oncological outcomes. And what is clear, and this was proven multiple times, especially in this study, which is a recent study for GCM, showing that we have to talk with our patient about the sexual expectancy and about the influence of the cystectomy on the sexual function. From that particular study, it seems that majority of women that were operated didn't know zero or nothing about the influence of the operation of the sexual function. So in conclusion, we can give the dietary advice, we can give the amitriptyline or any other suitable antidepressants, we can give GAGs orally and intravesically, we can inject botulinum, and we can operate those patients. So at the end, I've got a few minutes left, I would like to go through the subject of new ketamine neuropathy subject. That we all know the ketamine, this is the drug that is used for anesthesia, but recently is getting more and more common in the recreational field, especially in Asia. On the black market is much cheaper when compared to cocaine or heroin. It's called Key, Special Key, Dorothy, KitKat, whatever, and it gives powerful hallucinations and near-death experience. Now we've got better and better literature showing what does it do to the urinary tract. So it gives some direct toxic effect. It damages small vessels, gives autoimmune reactions, and promotes infections. And symptoms, normally those more severe symptoms, arise after 1.5 years of abuse of that drug, but can be present even earlier. A majority of those symptoms are classic LUTs, but after some time, all of those patients end up with fibrotic bladder, with bilateral hydronephrosis, and some renal papillary necrosis. And this is typical picture of CT urography with bilateral hydronephrosis, contractile small volume bladder. As I said, any LUTs can happen. The most common, of course, are frequency, urgency, or the trousseau overactivity, but any of those can happen. How to treat it? Of course, we have to ask the patient to stop the abuse of the drug, which is not always that easy. We can use anticholinergics, we can use some neuropathic agents, we can use botulinum, and of course we can use the GAC installations. There are some studies showing that it works, maybe not super good studies, only case series about few patients, but showing pretty nice results. We can also operate the patient. In some patients it's impossible not to perform the cystectomy. However, the patient must stop the ketamine use. And in this particular study, which I'm citing, only 1 for 320 patients were able not to take ketamine for more than 6 months. Thank you very much.
Any questions? So just to give you the first one, indeed, you really emphasized in a correct way the role of glycosaminoglycans and hyaluronic acid and so on. Can you in some way emphasize the role of hyaluronic acid and especially the side effect that are essentially nothing? So can you emphasize what is your suggestion, oral, direct instillation? What are the main recommendations you can summarize?
So the main recommendations are pretty poor, as I showed on the slides, but I can tell you what we do in our department and what are our, let's say, intern ideas. We give it, in majority of patients that we give it are females with recurrent infection, and those with radiation cystitis and those with chronic pelvic pain, of course. I personally love to give it intravesically. I'm not that convinced about the oral way because of some metabolizing issues, but giving it intravesically works pretty great in majority of people, maybe not as a complete cure, but in majority of patients got some degree of relief. Yeah, the biggest group that I have treated, or me with my team have treated, younger females with the recurrent urinary tract infection. The main idea is to give a bit more rather than less of those intravesical installations. However, the hypothesis is that even giving 2 or 3 installations in those people with suspected real damage to the GAC layer can be sufficient because of course, the economic factors that can hamper the buying of the drug by patients.
So to follow up on that, I think that's extremely interesting because this is a group of people where we don't have a lot of treatments, and we do the intravesical installations as well. But do you keep them? Do you do them chronically, or do you give maybe, now you said 2 or 3 was too little, but then do you give 4 or 6 and then you stop for a while, or do you keep giving them with an interval? It's a chronic treatment.
As you know, it really depends on the patient. There are some that can afford it for a long time, so there is no question for that. And if it's efficient, you can give it chronically. Of course, the maintenance is much rare when compared to the introduction part. However, in those patients, when it works and they cannot afford to buy a lot of those syringes, we tend to give at least 3, and after that some time of pause, and after that we come back with 3 more.
Okay, that's very interesting. So for us, it's not a financial issue for the patients because this healthcare system is paying for it.
In Poland, it's not reimbursed. There is a way to reimburse it, but it's complicated. You have to do it inward. You have to admit the patient, so it's not that easy. So the patient has to buy it.
Right. So I think, yes.
I was wondering with one of your last slides about ketamine cystitis, because since several months we got in Poland the drug program for the treatment of drug-resistant depression with esketamine, which is given intranasally. And in the drug label, it's been described that increased frequency of dysuria might be an often side effect. Personally, I never met these symptoms in my patients treated until now in the hospital with esketamine, and I was wondering whether you had these cases. Maybe it can reveal in a longer course of time.
So in my personal experience, I didn't have neither any patient, and I went through the, preparing that talk, I went through the literature about the drug that you're mentioning, and there is no proven there is no proven case of ketamine-induced uropathy because of antidepressants that can be prescribed. It seems that it's safe, but the observation is, I think, too short to be completely sure.
Is there anyone who want to share his experience with hyaluronic acid? Yes, please.
Professor, on one of your slides, you mentioned hyperbaric therapy. We at the Military Institute of Medicine, Szpital na Szaserów, we've had great outcomes of treating post-radiology or post-radiology cystitis. So with hyperbaric therapy associated or supplemented with installations of hyaluronic acid, and that is refunded by the Polish health system as in interstitial cystitis or bladder pain syndrome. It is not refunded, but also those patients have to pay for it. Those patients that do afford the supplementation of installations with hyperbaric therapy, from my experience, has a great outcome. Thank you.
Yeah, I completely agree. In those patients with hemorrhagic cystitis, after the radiotherapy, after radical radiotherapy, when those patients got so-called treated cancer and no signs of viable cancer in our center, they love to do it, and it's pretty effective, especially when done multiple times, like 50 times or whatever. But we have a problem with our specialists. They don't want to do it in those patients which have radiation cystitis during the treatment, and that for us is the biggest problem.
Any other questions? Kobi, can you give your idea, your experience in the Netherlands?
I totally agree that we need to work multidisciplinary, and it's not one modality that gives the solution. But we also need, what's happened a lot of time is that there is a mix of diagnosis. Interstitial cystitis need to be diagnosed with a biopsy, with all the modalities. We have the chronic bladder pain syndrome or the chronic pelvic pain syndrome, and the word syndrome says that it's a combination of symptoms we don't know the cause. It doesn't mean that the patient don't suffer, they suffer a lot. And the radiation cystitis is another modality. I think that Mikkel would talk something about it. So there are different modalities and different diagnoses, but in all of them, the patient suffers tremendously, and we don't have the ideal solution. So we need to be honest with the patient that we understand that they have pain. We need to be honest that we are doing our best to improve the quality of life and reduce the pain, and that the hyaluronic acid is a possibility. Always, to my opinion, involve the physical therapy, because we don't know what is the chicken and what is the egg. Is the pelvic floor was there already, or is a consequence of the pain? And we need to deal with the patient also psychology, not as urologists, etc., but in this aspect of coping mechanism and dealing with pain like any other pain or chronic pain patients. And that's the only way that we have nowadays. Let's hope that we will have better solutions. But I think that also the research, because a lot of publications are a mixed patient population, and these are not the same patients.
Sure, I totally agree.
Any other questions, idea? So, Mikkel, for sure, I have a question for you, or to share with him. As also Kobi mentioned, there is a tremendous reduction of quality of life, and for sure an influence on mood of these people. So what do you suggest? You mentioned also the possibility to use antidepressant, but you mentioned that there is the possibility of side effect. So what is your opinion? What are the antidepressants that can be used with low rate of side effect, and what is your opinion?
I'm a simple surgeon, I'm a simple urologist, so I don't have vast experience in that. I have a let's say, good cooperation with our psychiatrists. So any doubt, I just refer the patient to psychiatrist who would be better in that particular drug tailoring than the psychiatrist. But of course, you can try with those drugs if you do not have a privilege to work with that people that I do. You can use what the guidelines say, amitriptyline in low dosing, being very cautious about it. Yeah, you can try it. But my idea is, as a simple surgeon, be cautious, and the best option is to refer the patient for the specialist.
Mikael.
Thank you. I also have this experience on the other side, so cooperating with urologists. I'm going to keep you in a little bit tension because I'm going to expand this in my talk, so I'm not going to answer all this question to you, Giovanni. But there are some psychiatric drugs that are very well known among urologists, as they used to. Yes, the Dapoxin is one, but it's more for premature ejaculation. But I mean, like, I'm going to talk a little bit on duloxetine as well, and amitriptyline was mentioned. Hydroxyzine is quite widely used. The thing is, as my one remark for this moment, and I'm going to expand this in my lecture, it's quite important to see this in the broader perspective. So it's not only the symptom, it's not only the medication that cures the symptom, but it's the whole story of patient mood and subjective reaction to pain, to urgency, and everything. Sometimes you need also not only behavioral but also psychotherapeutic approach, which might be highly needed for this patient, also in order to keep them properly in urological treatment, I believe. So I don't know what are your...
To be compliant with the treatment.
Yeah, definitely. So I don't know what are your experiences on that.
Completely the same. As I'm not experiencing psychology stuff, I just refer them and work closely with the specialist.
So this is also the multidisciplinary work. Okay, I'm going to talk later more about it.
Just to add, even as urologist, okay, I'm also a urologist, we can be a plumbers, but we can take care about the patients.
Sure.
So when we refer to the psychiatrists, majority of them don't pay any attention to sexuality and sexual health. So we can approach that. That's one aspect that I want to emphasize. I don't know if in Poland cannabis is allowed.
It's allowed in medical purposes.
Yeah, for medical cannabis can certainly do some work on the pain, and certainly can have effect on the experiencing of pain and sleeping, and that improve already quality of life. At least the one who reduce the inflammation reaction with the sativa species and not the indica. That's our experience in the Netherlands, and I know that 20 years ago when a patient tells me I use cannabis and since then I have much less, I was like, yeah, addicted, now I changed my mind. But that's how it is, so it's also a possibility.
Any other question? Anyone has experience with the use of hyaluronic acid? So for sure, I think the key message coming from these two lectures is that the huge number of people suffering from this disease. This is a combination between maybe some organic damage, obviously post-radiotherapy for sure, but also post-infection and so on, and probably considering the pathological underlying mechanism, maybe autoimmune chronic inflammation can support this cycle. For sure, the combination between different kind of therapy based on the use of hyaluronic acid can improve the symptoms, but we need to have a multidisciplinary approach, including Mikkel, including urologists, maybe including endocrinologists, because there are also some problems with new anti-diabetic drugs that for sure can in some way emphasize these symptoms. And I think the SSM can be the house of this multidisciplinary approach. I don't know, Mikkel, if you can give some final remarks, then we can have a coffee break.
Absolutely, I'll echo this, and I think what's very interesting in this is that there is a lack of clinical research. I was really impressed with both talks. They were very excellent, and you showed us some meta-analysis. But we have to remember the lack of strength in the studies behind those meta-analysis. So clinical, and also there's a lot of different ways things are being done. So really clinical experience is very important here. For that, just from my experience with our patients, we don't have very good results with Botox. We've had some very bad cases where people had urinary retention, which is devastating in a bladder pain syndrome patient. And very often when we tell the patients that's a possible side effect, they even opt out of the Botox. So we don't have good experience, but I know the studies, and I know other people's experience are different. Then for the surgical, and this is just a remark, for the surgical intervention, that's also obviously a last resource, but I think maybe it's even being done too little. We do urinary diversions if we do it without cystectomy, and we actually have quite good results with leaving the bladder in.
But we have to remember that when you do that, you have to perform cystoscopy, or even further examination of the bladder, as this is the risk of bladder cancer. This is a very good point to make, that if you leave the bladder there, you have to examine that after all, because of the risk of bladder cancer development in the residual bladder.
So these were all very interesting discussions.
I had two patients like that with advanced cancer that was urinary diversion because of whatever, and they both died because of uncontrolled bladders.
And I think a comment like that is really the value of discussing this and discussing the clinical experience, because we're not going to see something like that in the literature.
So it is my pleasure to introduce Anna Nowiczka from Warsaw, the link between urinary tract infection and sexual disorders. Please.
All right. Hello, everybody. I think I'm done. All right. Well, as I had my first plan of lectures, I was supposed to talk after Professor Kajewski and Professor Lewsterowicz. And my friends, when they saw that and asked me, is there anything else to say? Is there anything to add after such wonderful lectures? But I believe it is. Urinary tract infection is absolutely common in our society. It's mainly a female heavy state of health that we have to deal with. And I strongly comply with the attitude that acute versus chronic infection and recurrent cystitis are three different sets of problems to dissolve. They are three different diseases that we have to take a different approach with. There are different causes for this state. There are different interventions we can use. It sets our diagnostic procedures in different ways. It is in uncomplicated cystitis. The mainly clinical symptoms and basic urinary analysis is enough to set a diagnosis, and it is insufficient for patients that have recurrent symptoms that experience acute cystitis many times in a year, especially if it's related to sexual activity, if it's related to weather changes, to traveling. Those patients are in high risk of insufficient diagnostics and wrong treatment. The classification is well known to everybody present at this room. It is taken directly from our European guidelines. We know that uncomplicated UTIs are the acute state that is combined with urgency, with dysuria, with pain, with nocturia, and to call it uncomplicated, we have to limit it to non-pregnant women without any functional or anatomical abnormalities. If her urinary tract system is unobstructed, we call it uncomplicated, and everything that comes above that, every risk factor causes are combined with, they make us treat those patients differently. If we talk about men with such symptoms, or women during a pregnancy period, or any relevant anatomical or functional abnormality of urinary tract or indwelling catheter, this sets a different set of concern that we have to take into consideration. Recurrent UTIs, on the other hand, might lower our involvement, because for many doctors, for many patients, it looks like it's just an acute cystitis. It just happened many times in a year, so it is not a big deal. And what we have to take separate approach from this is asymptomatic bacteriuria, which is very easy to detect. It takes only a urine sample. And if patient is asymptomatic, it doesn't require any treatments if there is no risk coming with pregnancy or approaching urinary procedure involving mucosa. But our patients receive a treatment for this. Most of us seen at least a couple patients that had recurrent antibiotic treatment, even with broad spectrum antibiotics, only to clear the urine analysis that was taken randomly or for no reason. Our general practitioners, our colleagues in gynecology, or even nephrologists are trying to achieve sterile bladder, because they believe that bladder should be sterile, which is not the case. The more we know about molecular diagnostic procedures, we know more that there are commensal organisms living in the bladder that not only communicate with themselves, but they also communicate with our body. And asymptomatic bacteriuria is the more women gets older, the prevalence of asymptomatic bacteria grows. If it comes with diabetes, or if a woman is in elderly population that lives in the institution.
Should be working. But it's not.
So every resident of institutionalized care facility has a higher risk, substantially higher risk of asymptomatic bacteriuria, and those patients are under strict care of nurses and doctors working in those institutions. So it's very obvious that every time they express a concern about their genital area, the first thing is going to be taken is a urine sample for simple analysis, and that brings a risk of unnecessary antibiotic treatment for that patient. Every time we detect bacterial growth over 10 to 5 colony forming unit in milliliter in 2 consecutive samples in women, and every single sample in men is a sign of asymptomatic bacteriuria. As we begin to more and more realize that commensal bacteria living in the bladder act protective against uropathogenic bacteria that can enter the bladder from wide and short urethra, especially during sexual activity. So our guidelines, as you all know, strongly suggest that we don't search for, we don't screen for, and we don't treat asymptomatic bacteria at all. And study shows that the only reason it makes sense only to treat that asymptomatic state if a woman is pregnant for 9 months of her pregnancy. She should be screened for asymptomatic bacteriuria, and she should be actively treated to prevent her infectious complications during pregnancy and to prevent low birth rate of her child, birth weight. And the other set of patients that require treatment in that situations are the ones that are prepared for urologic procedures involving mucosa. We all know that uncomplicated cystitis is a absolutely common thing. Every second woman will experience that in a lifetime, and 1 in 3 will have it at least for one episode before reaching 24 years of age. So we all know, and our societies know, our young doctors know, and they all are fully aware that uncomplicated cystitis is self-limiting, not life-threatening disease. So it tends to be taken lightly. But the risk factors for uncomplicated cystitis are sexual intercourse, as the bacteria from vaginal vestibulum enter bladder through short urethra, use of spermicides, which changes biology of vaginal flora, and new sexual partner is a separate, independent risk factor for a woman's lower tract, as he brings new sets of bacteria into the picture. And also those genetic hardships that our patients deal with when there is a mother with a history of chronic UTI, or a woman or a patient had a UTI during childhood. The majority of cases of uncomplicated cystitis is caused by E. coli, and that sets our actions in that direction. Well, in this management of uncomplicated cystitis, antimicrobial therapy is recommended. We all know it's self-limiting, which means that 3 days course of antibiotic or 3 days of ibuprofen will have the same effect on symptoms control. The only difference is that women treated with antibiotics will have lower rates of recurring symptoms comparing to those who were treated only with painkillers, with anti-inflammatory drugs. If a patient presents mild to moderate symptoms, systematic therapy, the control of symptoms, might be an alternative for antimicrobial treatment, and it should be considered, especially that we are facing growing resistance to our antibiotics worldwide, and Europe is not an exception in that field. So we have to take every step necessary to protect antibiotics so we can use them for a bit longer. Routine post-treatment urinalysis or cultures are not indicated if a patient remains asymptomatic, and it's still a sentiment directed to prevent unnecessary antibiotic treatment if a patient presents asymptomatic bacteriuria after proper antibiotic therapy. And you all know that it's management of uncomplicated cystitis recommended by European Urological Society. As we can see, the short-term treatment are highly recommended for every woman with uncomplicated cystitis. And not all those pharmaceuticals are widely available. Nitrofurantoin is not available in Poland. Instead of that, we have furazidin, which is not an antibiotic, and it's combined with tromotanol that gives instant relief to our patients using it, but the majority of patients present recurrent symptoms after treatment with that pharmaceuticals, and it's unfortunately widely advertised, and it's delivered over the counter. So if a desperate patient enters any pharmacy in Poland, and instead of saying good morning, she would say brother, there is a 100% chance that she will receive that kind of drug to buy. Alternatives for first-line treatment are cephalosporins, and there is a reason for them to be given as an alternative because of collateral damage on intestinal flora they cause. If the local resistant patterns is below 20% for E. coli, there is a chance to use trimethoprim or trimethoprim sulfametoxazole also for a short day treatment. It is obviously not recommended during pregnancy, and it's directed mostly to men presenting with symptoms, mostly because it has good penetration to prostatic tissue, which gets involved if there is a urinary tract infection. Well, getting back to those, we no longer use fluoroquinolones because since 2019, when European Commission put restriction on that drug's usage because of collateral damage on vaginal and intestinal flora, there are complications on neurological system and also environmental damage because active forms of drug are concentrated in urine, which means that every patient treated with fluoroquinolones is a source of active drug delivered to environment. And this is the other reason that leads to growing bacterial resistance. When talking about chronic urinary tract infections, we have in mind a patient that experiences at least 2 episodes in 6 months or 3 in 12 months. And it doesn't take a rocket science to imagine that it impacts negatively patients' quality of life and reduction in the quality of social and sexual relationship, harasses self-esteem and capacity for work. Patients that suffer from chronic urinary tract infection, if she's young and premenopausal, sexual activity, use of spermicide, which is the case in most of sexual activities, and a new sexual partner are those 3 independent risk factors for a woman to deal with, to face chronic urinary tract infection, especially if her mother had a history of UTI or if she had it during her childhood herself. After menopause, another set of problems comes into picture, because if a woman has to deal with urinary incontinence or atrophic vaginitis due to estrogen deficiency, that sets a huge risk on her course of disease. The management is different. As I mentioned earlier, it's a different kind of disease comparing to acute cystitis. It in the first place, it contains avoidance of risk factor, and after that, non-antimicrobial measures, and at the end, antimicrobial prophylaxis. And this is the order of our interventions that should be taken. Any urological factors should be identified and treated, especially patients should be advised on behavioral modifications to prevent long pauses between using a toilet or fluid intake. Her hormonal replacement therapy should be taken into consideration if there's a need for this. Immunoactive prophylaxis is a growing subject in Europe and Poland as well. At the moment, we have only one pharmaceutical that delivers such effect, and 3 others are on the way, still in studies. Prophylaxis with probiotics, just to set a proper environment in her vaginal flora, and endovesical instillation to cover the urothelium with protective layer of glycosaminoglycan to release the symptoms, but also protect her from bacterial adhesion and fast return of symptoms. Metamine hippurate, it is not an antibiotic, it delivers active form of formaldehyde into urine, which disinfects the bladder in some way. And I wish I didn't have to say that, but our guidelines provide also antimicrobials for preventing UTIs. And my heart screams when I have to say about continuous low-dose prophylaxis, because as a member of antibiotic control team in my hospital, we realized that many months of insufficient dose of antibiotics just put our patient into the risk of collateral damage in their intestinal and vaginal flora. We are fully aware that compliance for many months is unachievable in many cases, so the serum concentration of antibiotics won't be sufficient to protect our patients from urinary tract infections. Postcoital prophylaxis has a bit more sense. It doesn't have to be done with antibiotics, preventing urological risk factors can be done for postcoital prophylaxis without antibiotics. But self-diagnosis and self-treatment is an option for very limited set of patients that can work under symptoms by themselves. And you've seen that already. Professor Krajewski showed that we have many and multifaceted approach to deal with patients with chronic UTIs. And this is the thing that our residents have to learn for their final exams. So when they deal with oncological guidelines, operational trauma, and everything, that they tend to think that chronic urinary tract infections, it's not a big deal. It's relatively easy. And I sometimes hear them talking that, you know, I have a patient that comes to my office with the same symptoms over and over again, and the other one replies, well, it's not a big deal, just give her some antibiotic. And he says, I already gave her that and this. And he says, well, so why don't you give her something else? There must be something. Is it that simple? Apparently it's not. Our chronic UTIs is female-heavy condition. Mostly women are affected with that. And if we take into consideration that our patient have to deal with gender bias in doctor's office as well, their symptoms are often disbelieved and underrated, because studies show that men dealing with chronic pain will be considered stoic or strong or resilient, and a woman presenting the same set of symptoms is much largely prone to be described as hysterical or overreacting. So their symptoms are not taken seriously. And when our patient is complaining that she feels that she's paying with pins and needles, or that her brother is filled with razor blades, or when she's claiming that she spent the night on a toilet suffering deeply, we should take that into consideration, that it's not overreacting, it's not acting as sometimes we tend to believe. It doesn't take a rocket scientist to understand that after a painful night spent on a toilet, a woman on the next day feels terribly. We also have gaps in medical research. Some of those are directed only to men, because it is a nightmare to prepare a study that will take into consideration menstrual cycle and estrogen deficiency. So the women have to deal with delayed diagnosis and inadequate symptom management, especially pain treatment is lacking. Women tend to receive weaker drugs to control their pain. And also, our female patients have more risk to be diagnosed with psychosomatic disorder, instead of searching for deeper reasons for her presented symptoms. So it's not simple, especially when we take into consideration who we are dealing with. Because every time we talk about infection, we have to consider not only bacterial virulency, but also the host response. And in treating patients with chronic urinary tract infections, we have to take not only a doctor that might be biased, but also a female that is presented in our office. If she took months to get into urological office, it is very often that she's been ridiculed or humiliated in a previous attempts to find a solution for her treatment. So it's not unusual that she'll be said that it's all in your head, or you must do something wrong, or especially my personal favorite, those symptoms will go away when you deliver your first child. And as my brilliant colleague pointed out yesterday, in fact, when she delivers her first baby, her picture of chronic pelvic pain is her innate feature. And we have to take into consideration that women are pretty busy. More young women are attending universities. In Poland, 87% of medical graduates are women, and many other fields are heavy with that statistic. The labor force precipitation is lower among women, must be admitted, but we must also remember that this is the work that she earns more. She works on a sticky floor. There's a glass ceiling above her head, and with the lower income she receives, she must pay pink taxes. And and deal with money in a different manner. If a woman is in a relationship, her time is consumed also at her home, because living with a man in a relationship brings additional work into woman's day. Her household is run predominantly on her time and with her effort, and not to mention that motherhood brings huge effect on her career and her career progression. And then we must also remember that having a first child is like an earthquake and a thunderstorm at the same time, rebuilding a woman's life in totally different manner, and putting somebody else in the center of her intention for the rest of her life. And the average hours the parents spend with their children, caring for them, and for household activities and doctor's appointments and preparing meals. There are lots of things that goes unnoticed and underappreciated in households. If we deal with society with insufficient social safety net, if there's a need for taking care of elderly adults, if there's a daughter in a picture, she's prone to take responsibility for taking care of elderly in her families. And also, the women are known to create communities. They get engaged into charity work, and women tend to take huge part of their lives of each other. Which is great for them to have net of support, but it's also very time-consuming. And there are parts in Europe and America as well where there are other set of local, may I say, things to deal with. So there's an emotional labor that is put mostly on women's shoulders. And chronic urinary tract infections that take a woman away from her normal daily activities, which are a lot. It also affects her sexual health, because if she experiences pain in her pelvic area, so that pain, but also the fear of recurring pain, is a torture on her. Postcoital societies is an issue, because there are a particular part of women that experience chronic symptoms right after sexual activity. And that fear of pain is disturbing her, is creating resistance to penetration and pelvic floor hypertonus that is a cause of dyspareunia and mucosal trauma. And it creates a vicious cycle of symptoms and complications that lead to sexual avoidance actions. There's also depression and anxiety that is highly prevalent especially if a woman feels hopeless and frustrated, and if there is a guilt involved for symptoms that recurring, even though they are treated with high emphasis. And also with that, she has to deal with partner's frustration and erectile issues. If she's experiencing pain, it will affect both of partners. So getting back to that management that is mentioned in our guidelines, we have to take huge action to use to consider every single part of recommended procedure. That layer of glycosaminoglycan is it covers urothelium and prevents the noxious urine components from irritating the mucosa. And as we've heard previously, it can be damaged through radiation, through irritation with stones or intravesical bodies, and even antibiotic treatment is a reason for gaps and disturbance in that layer. So if the urothelium is exposed to urine, women will sometimes present in our office shortly after antibiotic treatment, and she will say, well, I know it's done, I know the treatment is over, and I'm sure that inflammation is resolved because I have no pain, I have no urgency, but I still have some kind of undescribed discomfort spreading in my lower abdomen. So it is a symptom of irritation through gaps in glycosaminoglycan layer. And that undescribed discomfort is a huge impact on females' quality of life. So if we replace that with endovesical installation, it brings a relief to our patient in her daily life.
1 minute left.
Thank you. So what else can be done? I highly encourage all my patients to become an expert in a field of her bladder, and I encourage them to identify all risk factors that bring them episodes of urinary tract infection, of chronic disease, manage estrogen deficiency. I highly recommend them to improve their physical activity, not only for her muscles and tendons elasticity, but also for antidepressive effect that physical activity has. I'd also encourage them to smoke water, to stop smoking and drink more water, and avoid bathroom breaks, and consider change of contraceptive method if there's a need for this. Thank you very much.
We have space for one short question. So just to emphasize again the role of hyaluronic acid even in people with frequent urinary tract infection. One point that I want you can summarize and emphasize is maybe the role of postcoital infection and the use of antibiotic treatments, and maybe the space of hyaluronic acid in this particular group of patients.
There is a huge space to use hyaluronic acid in that group of patients, especially when there is sexually transmitted disease excluded. If urethritis due to ureaplasma and mycoplasma and chlamydia is excluded, so that sets our patient in the group of those suffering from postcoital urinary tract infection, and antibiotic is not the only option. We can sterilize the bladder with methenamine, cuprate, and herbal drugs and plant supplementations, everything that releases the inflammation and clears urine bladder. But also endovesical installation help a lot, especially when patient is aware that there's a risk factor approaching. I have a set of patients that enter my office every time they leave for vacation, every time they tend to change climate. If they're traveling, they just receive one dose of endovesical installation to prevent chronic infection, to prevent another episode, to cover the urothelium with protective layer.
Thank you. Mikkel, any?
I think the time is running now. I think, as we were talking about before, this is an area with not a lot of research and a lot of clinical experience that's very important. So I think a talk like this from an expert is very helpful. Thank you so much.
Thank you.
Thank you. Now it's time to introduce Mikkel Fod. Mikkel Fod is Professor of Urology at Copenhagen, but also the President-elect of the SSM, is going to release a talk on post-radiation cystitis and sexual dysfunction. So please, Mikkel.
Thank you so much. And I guess we are continuing in the same track, right? These are things that clinical experience mean a lot. So I'll be very happy if we can have a little bit of discussion after the talk, probably. My topic, post-radiation cystitis and sexual dysfunction. So the idea behind this talk is to talk about both conditions and then to kind of bring them together and see how does the post-radiation cystitis affect sexual function, and then talk a little bit about the management there and hopefully have some discussion with all of you. I'll show you a picture first of my hospital. This is Herlev and Gentofte Hospital right outside of Copenhagen. 2 departments, about 100 urologists, and we see a lot of these patients. We're a tertiary referral center, and we kind of have the tradition with us that we keep the patients with us. Also the pain patients and the recurrent infection patients. And what also happens, which is an important aspect that we haven't discussed so much, is that the patients need support. So it's also an aspect that I've been sitting here thinking about, that the patients come and see a doctor once in a while. It's very important for them because they don't have any other support. So we need to, in these patients, really consider their whole life and not necessarily pretend that we have a treatment that's effective, having them come in and offer the treatment and then sending them out again just as an excuse to see people. We have to consider the whole person. So just as a message that we try to be very aware of with us. So to begin the talk, the definitions of radiation cystitis and sexual dysfunction. I'll take off the microphone here. Radiation cystitis we already heard about. It's bladder inflammation due to radiation therapy, and the bladder can really be very affected, as we saw in some of the pictures in one of the excellent talks earlier. Sexual dysfunction can be defined in different ways, but basically it's problems during any phase of the sexual response cycle preventing satisfaction ultimately, and that can be in both men and women. And both of these conditions, both alone and together, significantly can impact the quality of life. There's no question about that. So this is really a very important thing. So I'll try to enhance the understanding, discuss the management, and highlight some of the support strategies. And we'll start by trying to understand radiation cystitis. Now, a few things can happen, and people radiate it for very severe reasons. Obviously, it's almost always cancer. That means that they have radiation in the pelvic region. This can be directly to the bladder, or it can be to surrounding organs. And there is more attention made, and you'll see that later on, to prostate cancer, but really this is about all of the cancers that can be radiated within the pelvic region. There can be direct tissue damage, so the radiation near the bladder or even in the bladder can damage directly, especially the urothelium, as we heard about before. And then there's a lot of indirect damage as well. The blood supply can be disrupted, and over time that does mean that the bladder will get less oxygen and it will become fibrotic. So this can become a huge problem, not only with pain, but also with a reduced bladder capacity over time. There's some more complicated mechanisms, DNA damage and cellular mutations that arise within the bladder. This can cause inflammation. This can cause functional problems in the bladder. As we briefly discussed earlier on, there's an issue of bladder cancer as well, and this becomes very important in this group of cancer patients, because a secondary effect, long-term effect to pelvic radiation for one cancer is the development of bladder cancer. So this is very, very important also to be aware of. And we do have cases where secondary cancers in the bladder are neglected and overseen because the symptoms from the cancer is attributed to the normal damage, I would say, from radiation cystitis. So that's important to be aware of. And then we have a more direct activation of several inflammatory pathways. It's not, I think, in a clinical talk like this necessary to go into that a lot, but it means a little bit for how we can think about management of the patients, that really inflammatory pathways are very directly activated. But for the patients, what they present with are the symptoms, and these are very, very bothersome symptoms that we know from the other conditions that we've discussed today, just now the chronic and recurrent infections. Urgency, frequency, pain from the bladder, and then hematuria. So in the most severe cases, the bladder lining is simply bleeding. So the patients will present with that. Now, I think it differs where the patients present and where they talk about this, if this is taken very serious or not. But I think just for coming to a doctor, it should be taken serious. But I think it's important when we look at these symptoms that the barrier for a patient to even go to the doctor can be quite high, because these are embarrassing symptoms. You have to go to the toilet very often, and you have to go all of a sudden. It causes social isolation, and you can't really talk to anybody about that. There's quite a lot of research in overactive bladder that shows that the patients don't talk to anybody. They don't necessarily talk to their partner, they don't necessarily talk to their doctor, and they certainly don't talk to their friends and colleagues. So they can become more and more socially isolated. Again, we're back to looking at the whole person. This is not just the bladder issue, this is really a quality of life issue. So when we do the diagnosis, it's relatively easy, right? Because it's based on the patient history. When we're talking about radiation, cystitis specifically, they need to have had some pelvic radiation, obviously, and quite a brief history of it as well. So we always need to consider the differential diagnosis. So that's a urine analysis, not just a dipstick. We need to send the urine for growth to see if there are any bacteria, because we don't want to miss that and think that this is a chronic condition when it is just bacteria in the bladder. And there's an option to treat that, obviously, if it's there and if it's recurrent. And then the cystoscopy, we saw some of the pictures before how the bladder can look, and that's generally what we see. But we can kind of assess the bladder if it's possible to see that there is no secondary cancer, to look at the lining, to get the idea that this really does look like cystitis from radiation, and this is a damaged bladder lining. And I think that's it, right? We can talk a lot about the symptoms. We can go into detail with patient questionnaires. To me, they're not so necessary outside of clinical trials. You can get most of it just from talking to the patients. But always, I think, always remember to ask the patients, how is your life affected? Are there things you don't do because of these symptoms? That's really the key thing. Are there things you don't do because of these symptoms? You don't go out, you don't have sex, for example. Some of these things. So the radiation cystitis is quite common, and it differs a lot based on different factors, but the acute problems develop in 20 to 80% of patients that undergo cystitis, undergo radiation treatment. And again, by the primary physician, by the oncologists, providing this treatment, it differs a lot. Some are very, very good, and some really talk to patients a lot about it. But I've also experienced oncologists that really, I have to say, have the belief that they're treating cancer. They're doing something so significant for the patient. That's true, they are, but they're doing something so significant in their mind that the patient has to accept whatever side effects there are. That goes for sexual dysfunction, and sometimes that goes for urinary problems too. So it's important to take it seriously. The good news is, in most patients, this goes away by itself, or it gets a lot better by itself over time, but it does become chronic in about 5 to 10% of patients. So the risk factors for this is the total radiation dose. Obviously, the patients that have the radiation specifically on the bladder are at highest risk. If they have concurrent chemotherapy, there are some cellular mechanisms that mean that the risk of having these chronic problems afterwards is increased. And if they've had prior pelvic surgery, that's the same situation. And then if you have patients where the problem is compounded by recurrent urinary tract infections, these can both cause symptoms by themselves and exacerbate the problem, so make the lining of the bladder function worse and worse over time. But there is no difference of gender differences. A bladder in this case is pretty much a bladder, so it depends on where the radiation is given. So if we want to move on to the link between radiation cystitis and sexual dysfunction, there are a lot of things to consider. The first one is pain during intimacy. So if it hurts to have sex, people obviously will stop having sex, or they will be reluctant to have sex. And this is a very, very important thing. It's not only pain with sex, it's also pain leading up to sex. That's going to reduce the desire to start something sexual. For a female, it can decrease lubrication, physically decrease lubrication, and the corresponding thing to lubrication in the female is the erection in the man. And if you experience pain, that's also going to cause the erections to go down. So the pain is really, I think, the main thing. The second thing is the urinary symptoms and the discomfort from those. And there are two things. Being incontinent in relation to sexual activity, that happens to a lot of patients after radiation. And this is something extremely embarrassing and extremely difficult to deal with and extremely difficult to talk about. So if this happens to patients, they might be avoidant relating to sex afterwards, or even the fear of this happening, even the fear of urinary leakage in relation to sex is going to cause patients to stay away from sex and to not do it. And this is not very well documented, and in my experience, it's not talked a lot about before the radiation, certainly, that this is a risk factor. So it's very difficult for the patients to come in and talk to their doctor about this. One of my things, I'm a urologist, so one of my things is when patients choose between prostate cancer treatments in the form of surgery or radiation therapy, this issue is something to talk about. And so we did some research at my center. Actually, the risk of urinary leakage in connection with sexual activity is less after radiation than it is after prostatectomy. But how do patients have sex? What's important for patients? If oral sex is important for patients, this problem is huge. So that's actually something to consider in patients, even though it is quite difficult to talk about. Then there is an impact on sexual arousal and response, and that might be direct or indirect from both the pain and all of the urinary symptoms and the thoughts in the patient's heads. And then we have the psychological effects. The chronic nature of pain and persistent urinary symptoms contributes to stress, anxiety, and depression in general, and that can certainly affect sexual activity, and that can affect the desire to have sex. But another very great problem is the embarrassment caused by these symptoms and just the difficulty we have in our societies about talking about sex, meaning that patients will very often not talk to their partner about these issues as well. So they will just become avoided relating to sexual activity. They will stop having sex, and then the partner will have thoughts, is it me? Does it have something to do with me? And that goes both if it's a man or a woman. Is it something to do with me? And then that creates a cliff within the couple. So it's very important also to have patients talk about this. This is exacerbated because there's often a very direct impact on intimacy. There's a reduced frequency of sexual activity, and that becomes also a habit in the couples. So this can be chronic, even though the pain and the symptoms subside over time. If that takes a year and the couple haven't had sex or been intimate for a year, that gives a problem. It also gives the patient a confidence problem regarding sexuality if it takes time. So this is just not necessarily something we can just say, let's wait till it's over. The emotional distance I was just talking about between the partners can be quite significant. So it's really important. These simple things in this field that we don't know so much specifically about are really important. Talk to your partner about the problem. And if you can bring the partner into the consultations when it starts to be about sexuality, that will also be very, very important. Goes in the same direction. The communication breakdown between the partners don't have to only be related to sex. That can bleed into other parts of the relationship and be very, very problematic and even lead to a feeling of isolation within the relationship. Another issue is all of the patients that don't have a partner when these problems happen, they will have very, very difficult time finding a new partner because they know that they have these sexual issues. That is a huge barrier to meeting somebody new, and that means that this becomes not a sexual problem and not a urinary problem primarily. This also becomes a problem of real loneliness for some of the patients. So all of these intimacy, psychological issues are very important to at least consider. So if we move on to the more physical management and treatment strategies, there are some immediate management strategies for radiation cystitis that probably most of us have heard about. So we can talk about hydration. We can dilute the urine and kind of flush out any concentrated irritants. So just drink more water. That can be a specific advice we can give. Obviously, also pain management, over-the-counter pain medications such as non-steroid anti-inflammatory drugs make a lot of sense when we talk about inflammation problems in the bladder, certainly, and also acetaminophen, which is basically without side effects. These drugs should certainly be tried in the patients with pain. Morphine, on the other hand, has a very, very short window of justification. If you take morphine for very long, it's just gonna cause addiction. It's not gonna help the pain anymore. So please stay away from that in chronic situations. Then there are some dietary modifications, and we heard a little bit about that earlier today as well. And so in my opinion, I mean, it's something like alcohol, it's carbonated drinks, especially for some of my patients I've experienced, it's diet sodas, and it can be spicy foods or even citrus. But I think the important thing, or coffee, but I think the important thing here is to talk to patients that some patients experience that when they change their dietary habits, they change what they drink, then they have an improvement in symptoms, because this, in my experience, it's very individual. So if they really enjoy their coffee, don't tell them, don't drink your coffee. Maybe tell them, if you try not to have the coffee for a while, see if things get better. That's kind of how I try to sell it. Take away some things and see if it gets better. And if it doesn't, well, by all means, start eating them again. We have the anticholinergics. A lot of side effects, I agree with that. We heard that before. And the beta-3 agonists, in my experience, a lot more tolerated by the patients. Relaxes the bladder and reduces the urinary frequency and urgency symptoms. So obviously, these are some of the quite simple things that we can do. And if we do it early in the stage, we can try to take them away from patients so it doesn't become chronic medications in people that are naturally getting better. So I would try them. If they work, have the patients keep taking them, and then take a break with them every 6 months, something like that. It's not a specific rule, but just it's not necessarily a lifetime medication when you go from an incidence of this problem from about 80% to about 10%. Then we have the bladder installations, which we've heard a lot about today, and I'll talk a little bit more about. Hyaluronic acid is probably the most important of them. And finally, antibiotics, if there is a verified urinary tract infection, obviously should be treated. Further treatment options in the long-term radiation cystitis is some of the things we've also heard about: hyperbaric oxygen therapy. So we deliver here a high concentration of oxygen in a pressurized chamber, and the theory is that this gives growth of new blood vessels, healing of damaged bladder tissue, and maybe it can reduce the symptoms of chronic radiation cystitis. We don't have a lot of research on this. We have a little bit, but certainly this is without a lot of side effects, without a lot of complications, so something that can be tried. The intravesical therapies, installations of drugs directly into the bladder, theoretically, that makes a lot of sense, right? We can rebuild, or we can try to rebuild the GAG layer within the bladder to make it function better. And then DMSO, an anti-inflammatory agent, we've tried it. We certainly use it at our center, and I have to say that's the back against the wall. Nothing else is working. And in my experience, this is not working very well either, but there is a little bit of research based on it. And then we had the surgical options that we discussed before. Again, in my center, we choose the urinary diversion, but there are pros and cons as discussed. Cystectomy is really a big surgery. And in any case, these are last resort treatments. But if they're necessary, considering what this means to the quality of life, I actually think they're underutilized, especially the urinary diversion. If nothing else helps, this is an option for patients, and this is something that can improve the quality of life quite a bit. So, to talk a little bit about the specific studies, we have hyperbaric oxygen therapy. Now, there are studies in other areas with this, but not a lot of randomized trials for bladder conditions and bladder pain. This study is very nice. It was published in Lancet Oncology. It's a Swedish study. It was the basis of a doctoral thesis in Sweden. 87 patients, and that also says something about our field. This is in Lancet Oncology, and it's a doctoral thesis, but it's 87 patients. They were randomized to hyperbaric oxygen therapy or standardized care for a number of sessions. And there was a significant difference in the symptom score. The EPIC urinary score decreased by 10.1 point versus 7.7 points in the standard of care group. But what I think is more important is looking at the individual patients. 64% of the patients had improved symptoms after the oxygen therapy. So this does look like it can do something, because it was a lot more than the standard of care group. And compared to the control group, there were significantly improvements in general health and physical functioning. So this kind of bled into other aspects of life as well. Now, this is a non-blinded study, obviously, because that's the limitation we have in these types of treatments. So there is a placebo effect here as well, but this does look very promising. To look at the intravesical installations, I have some of the same studies here that were presented earlier today, some prospective observational studies, which are actually very nice, mainly after prostate cancer therapy. But with the installations, there was a reduction in the severity of nocturia, which is obviously a very bothersome problem. There's a reduction in the symptom severity. There was a reduction in symptoms and health problem severity, meaning that there was an improvement in overall quality of life in these patients. Regression of all of the symptoms in urgency, frequency, nocturia, and pain. Reduction in frequency of urination and increased bladder capacity. Even in one of the studies, there was a reduction in hematuria. And basically, overall, the quality of life improved in the patients that had the bladder installations. So certainly, it's worth trying. But this is also one of the treatments that is very difficult to administer. I was asking the question after the talk before. Now the question is, how do we do it? Do we give 4 weekly installations and then stop completely? Do we give 4 weekly installations and then keep going forever with with more rare installations? Do we do it on an individual basis? What do we do? Now, this is very difficult, and becomes very difficult, I think, in my practice, certainly, because there's a psychological element as well. If these bladder installations are the only contact that the patient is able to have with the urology department, to come and talk to somebody who's actually taking their symptoms seriously, then that might give a benefit in itself. So we have to be very careful here how much we do it, and we have to follow the effect of the treatments. It can be effective, it certainly should be tried, but it shouldn't be done forever in all of the patients. Now, here is even better evidence that it can work in some patients. The others were prospective studies where you did have certainly all of the placebo effect and also the natural regression of symptoms. Here you have a randomized trial in European Urology Open Science, the new Open Science journal that's a part of the European Urology family now. And this were 49 patients randomized to either intravesical installations or observation. But the interesting is this was during radiation therapy for radical prostatectomy. So during the actual radiation therapy, this was happening. And there were significantly better urinary symptoms in the group that had the installations. So it does look like it was working. And there's a lot going on for these patients. Of course, there's going to be a placebo effect, but I do believe it's smaller in patients where so much is happening. And then we also saw a higher quality of life 1 year after these installations. So this is actually, it's preliminary because it's a small study. But I think this is very, very interesting. And it says that maybe we have a possibility to improve the lives of these patients. It's not just about the cancer treatment, it's about the quality of life overall. An important thing is, and there's research on this in prostate cancer patients, is that a proportion of patients that have severe urinary symptoms after the treatment, whether it's radiation or radical prostatectomy, they actually regret going through cancer treatment because they're so bothered by the symptoms. So this is very specific, I think, for urinary symptoms and pain, that this has a huge impact on quality of life, making people think I shouldn't have had cancer treatment, the ones that are affected most severely. So this is the bladder issue. If we move on to the therapeutic approaches for sexual dysfunction, I talked about this before. Open communication. It's so very, very important. And we have a lot of studies that show that patients are very reluctant to talk to their physicians about sexual issues. So when we have patients that we know are at risk, for example, after radiation therapy, we need to be asking the patients, should we talk about sexuality? Should we talk about sexual function? Now, some of the patients will say, no, I don't want to, or no, we don't need to. Sex is very individual. It means something different for different people. But for a lot of patients, this is going to be an important question because it opens up the floor for them to ask the questions that they've been afraid to and reluctant to, because this is an embarrassing situation for them. And then we can offer some specific counseling or sex therapy. So talking to people, basically. I'm not the best at that, but I have people I can refer to. We have also the specific pain management I want to mention again here. We talked about this a little bit before, but pain relief can be related, so the patients will take it directly before sexual activity. And that's also something to think about. And then there is lubrication of with water-based lubes that can reduce the friction. And this is something very simple that sometimes we don't think to talk to patients about. For vaginal moisturizers can also be a possibility, or even local estrogen if there's dryness in the area. So these kind of simple things really can mean a lot. There's also a possibility to modify sexual activities. Different sexual positions can be less painful than the sexual positions that patients are used to. And this is not something that people necessarily figure out themselves. So even if we don't know a lot about it, we can refer them maybe to somebody who knows about this and is able to talk to them about this. Or we can, even if we can't do that, if we don't have the possibility, we can open their mind to it. Because they would probably, if they communicate in the couple, be able to do research themselves. But they have to think about it. And this is actually, if we're talking pain, pretty important. Then the schedule avoiding. Most patients have thought about this before themselves. Basically go to the bathroom before sex. And that means that you can empty the bladder, so the risk of urinary leakage during sexual activity is less. There are also studies in men after a radical prostatectomy with penile rings to constrict the urethra. John Mulhall has published on this with good results, so that's a possibility to reduce leakage. We've tried it, I would say, in my center, and patients were not very happy with it. It didn't work too well, so I'm a little skeptical on that, but certainly it's something that can be tried. And then we can talk about stress reduction techniques. Deep breathing, meditation, yoga, it may reduce stress, it may reduce tension. This is not something we have good evidence about. There is something about mindfulness and sexual activity, but this is again trying to think about the whole person and seeing what we can do to improve them. And then one thing that's maybe even more important than all of this is the pelvic floor, to think about that. We touched it a little bit earlier as well, that patients that have pain in the area, over time, a lot of them will become very tense and they will have a very painful pelvic floor and painful pelvic floor muscles. And it is so important to have them referred to the right physical therapist, because you send them to the wrong one and they will teach them to tense up their musculature even more and make the problem worse. So this is really something that can be considered and something that can be a chronic problem that's often overlooked in these patients. We all know it, and this is what I tell my patients when I try to convince them of this. We all know it, that we can have the problem in the neck muscles, right? We all tried it, and you become very stiff, and you can even get a headache from these stiff muscles. And kind of when I tell my patients that, then they understand that it makes sense that it can also happen in the pelvic area. So this is very important to open them up to the idea too, and that they don't feel that we're saying that there's nothing wrong with them. Finally, I'll talk about sexual health rehabilitation, and basically be aware of underlying sexual dysfunction. Up to 50% of these patients will have had some kind of sexual dysfunction before the radiation therapy. Now, lubrication doesn't get better after radiation. Erections don't get better after radiation, certainly. So if there were problems before, there are going to be problems after, and we can do that with the normal treatments, for example, the PD-5 inhibitor for the erection. And then there are specific problems also caused by the radiation, aside from the cystitis, ED, decreased lubrication. Again, the nerves and the blood vessels going to the genitals will also be affected by the radiation, and that's going to cause problems. The special thing about that is it doesn't necessarily cause problems in the beginning. That tends to be something that's caused more over time with the chronic affection and with the fibrosis. So that can get worse and worse over time, and we need to treat that in the normal manner. And then finally, of course, include a focus on the partner and the relationship. Now, the partner, be it male or female, may have specific dysfunctions as well, and this is something we need to make work in the couple. This is something that sounds very simple when we say it, but we often overlook it, especially me being a urologist. I don't know how to treat female sexual dysfunction well enough to do that. And as doctors, that's a terrible thing for a lot of us to have to say, I don't know, but I can refer. So it's not necessarily having to handle everything, it's discovering everything and opening up for the patients to talk about it and giving them the right referrals. And also the couple dynamics may have shifted. We're often talking cancer treatments, and a cancer diagnosis is stressful both to the patient and the partner. So there's been a lot going on in the lives of these patients. That means that we shouldn't focus just because we, for example, urologists shouldn't focus on the bladder alone. To expand on this a little bit further, more general psychological support can be needed in some patients on an individual basis, and information on supportive communities and educational materials. This will be very country and area specific, but if you know of anything, refer the patients. There's no patient associations for sexual dysfunctions, to my knowledge, but there's patient associations for the specific diseases that the patients have been treated for to begin with, the cancers, and other patients who's had the same experience will maybe be able to relate and talk about this. And finally, we are discussing a future ESSM initiative regarding support for sexual dysfunction in general. So in conclusion, radiation, cystitis, and sexual dysfunction both have impacts on quality of life and should be addressed by the physician if the patient doesn't talk about it. The two may be intimately linked, and treatments and counseling can be effective, so there is something to do, but more attention in the clinic and certainly more research is greatly needed. And to end, as we're all saying, please join us in Vienna for the next ESSM Congress in 2025. We really have an excellent scientific program spanning this and a lot of other topics within sexual medicine. Thank you.
Thank you, Mikkel. Any questions from the audience? Any comments? So, Mikkel, do you think that there is space to have a prevented use of hyaluronic acid? So, I mean, before the radiation therapy?
Perhaps it makes sense to do it before the radiation therapy. If you can create a GAG layer that's thicker and works better, maybe the actual bladder lining will be less damaged. But we would need to research that.
Yeah.
We need studies for this.
Maybe also another possibility is to combine the use of PDE5 inhibitors and hyaluronic acid, maybe in order to improve the oxygenation also of the tissues.
PDE5 inhibitors in tissue regeneration is certainly a theoretically interesting aspect, but the combination of these things clinically can make a lot of sense if you have both erectile dysfunction and bladder issues, obviously.
Any comments? Yeah. If you can come here in order to, yeah, please, come here in order to be on the camera.
Thank you, Mikkel. I always admire this biopsychosocial approach you put into your presentations. Just a very simple question. I wonder, as a practicing urologist within the hospital unit, at what time point would you refer or use this counseling part of the whole treatment in the patient history? So the patient comes to you with post-radiation cystitis or other conditions. When do you start with more psychological counseling of the problem?
So I think that's a very, very individual thing, because I think that most patients could actually benefit from having this way from the beginning and even before the radiation therapy. But patients are ready for this at different time points. So I think that the difficult thing in clinical practice with referring to this is that some patients, at least at least in my country, at least in my area, will feel, if you're not very careful and saying it at the right time, will feel that you're telling them that they have a psychological and not a physical issue. So you need to take this, you need to have them feel that you take their physical issue very serious first, and you need to give a try to treating that first, and then you need to talk to them in a very respectful manner about how this is not a psychological issue, this is the physical issue, affecting them psychologically and offering them this. But if I feel like the patient is ready, I can offer it very early. We have in my center now a couple of educated nurses that can do these talks, and if that's not enough, I have Anna Maria Giraldi basically in the backyard, so I'm very fortunate.
Please.
In your experience, in your center, what is the usual period of time when a patient with radiation cystitis comes in? Is it the onset of symptoms like irritation, pain, or is it a massive hematuria? Because from my experience, where I used to work at an oncological unit in hospital, in military hospital, the first patients showed up with, and we recognized, we diagnosed them with radiation cystitis with massive hematuria. That was the usual setting. And that's from my experience, that's the usual onset of symptoms, massive hematuria, and then when you start talking to them, they do admit that they've had some pains, but not very discomfort, not very high-level pains, rather discomfort.
Yeah, so I think that this is a personality issue for the individual patients very, very much, and certainly I agree with you. When they have the bleeding, they get scared, and then we see them, even if it's not massive, even if it's less than that, we see them with the bleeding. But I have a feeling that, and this is a feeling, that patients are accepting these symptoms with frequent urination and pain less and less, and they're coming more and more. But certainly you see it. Some patients accept very little and come to us very early with things that we say, okay, maybe we just give this some time, and some patients don't come at all. So I don't have a clear answer, but the majority of patients that we see now is because of bothersome symptoms and not hematuria.
Thank you, Mikkel. We need to move on, so it is my pleasure to introduce Professor Mikkel Liu Starovitz here, Professor of Psychiatric and Sexology here in Warsaw. So please, Michael.
Thank you very much. Well, first of all, please. Hello. That's better. Oh, thanks. First of all, don't believe in the information in your agenda. So I'm not going to talk about bladder-brain barrier. I'm just going to talk about brain-bladder connection. Here are my disclosures. And the other thing is that I'm one of two speakers here in the room that can say, welcome to my city, as my practice is located here in Warsaw, in the northern part of Warsaw, with this very huge city hospital, multidisciplinary hospital, surrounded by the forest and in a close neighborhood to the Center of Postgraduate Medical Education, which we have as a university clinic. That's my unit is psychiatry. And so it is quite important because we have this great opportunity as psychiatrists or as sexologists to collaborate with multidisciplinary teams or between specialists on different specialties. And I think this is what it's about. This is the perspective I'm going to show you. I should talk about brain-bladder connection, about the associations between urinary symptoms, brain and psychological mechanism, and on sexual issues, which is not an easy task. So it's basically it's material for at least 3 lectures. What I'm going to do is to take a sort of an overview to show you some basic ideas. So let's first move to the brain-bladder connection. So the whole coordination of urination between bladder and the central nervous system is a partially conscious mechanism where the sensory information coming from the feeling of the bladder comes to the central nervous system, and this is the moment when you feel it might be the time to urinate. But then there is the whole coordination within the brain, and especially the functional connection network between brain cortex, the medial prefrontal cortex, and brain stem, the pontine centers that are processing the information that gives you an idea about the urination timing. So when it is really needed, when it is possible. For instance, like sitting here in this room, you might feel, okay, my bladder is almost full, but maybe I still want to listen to the lecturer, then you can wait, so you can decide about timing. So this is the conscious part of the process. You don't have to run away unless you have some urological conditions you know much more about than me. And then this is this descending transduction of signals in the central nervous system, then on the peripheral level, that gives information to bladder and sphincter muscles, and they can either contract or relax. And how about bladder dysfunction and brain regulation? So there are 2 major conditions I'm going to concentrate. So first one is the neurogenic bladder or neurogenic lower urinary tract symptoms. And in case of brain, it might be related to the coordination failure by variable conditions such as from brain tumors, injuries, Parkinson's, other demyelinating disease like multiple sclerosis, so they can be drug-induced or even psychogenic. So there's a huge variety of different conditions that might be involved. And the second one is the bladder pain syndrome, which was so nicely described by Professor Krajewski today, with also many different contributing factors. But what I'm going to concentrate more on is the pain processing within the brain, which consists of the subjectively localized sensation. So it means that each part of the body has representation within the cortex, within the parts that are representative for different parts of the body. But indeed, the feeling or the pain feeling or any other sensation is a subjective feeling, and you have the very clear example of this in people who have so-called the phantoms aches, when they have amputated leg or arm, but they still can feel the pain in an area when there is actually nothing but air. The other thing is that pain has also is being processed within the pain neuromatrix, including structures like ungulate, anterior cingulate cortex, or insula, prefrontal cortex, hypothalamus, amygdala, and together with the sensory cortex, which the whole network leads also to many different aspects of pain processing, such as affective and behavioral reaction. And this is very nice example how affective processes influence the feeling of intensity of pain. For instance, you get a child who just fall down on the floor, get injured with his knee, and start shaking and start crying very loud. It aches a lot. And there comes the mother, takes a plaster on the knee, and then kisses the knee, and what happens? Usually there is a great relief of pain. It's not because the injury have changed, it's not because the wound was healed immediately. It's all about the effective processing of pain, and how important it might be. You can see very easily in children, but it is very often not taken into account enough in adults. So just to keep that in mind. Well, the interstitial cystitis or bladder pain syndrome can very often coexist with such conditions like fibromyalgia or irritable bowel syndrome. All of them, or chronic fatigue syndrome, all of them are known as important psychosomatic conditions and very often comorbid with mental health issues such as depression and anxiety. And moreover, conditions like overactive bladder and bladder pain syndrome are risk factors for each other, and they might be overlapped with each other. And as already mentioned, duloxetine is one of the medications that is quite widely recognized among urologists because it's been found to be effective in patients with overactive bladder and especially with stress, urinary incontinence. This is the drug that works not only, the basic mechanism is the selective inhibition of, selective reuptake inhibition of serotonin and noradrenaline, but not only within the brain, but also within on-off nuclei in sacral spinal cord. That is related to the increase of tension of striated muscles within the urethra. So that's why it might influence so much the urinary symptoms. And looking deeper into comorbidities rates, you get this cross-sectional internet survey performed in 3 countries called EPILATS, and it was found that the presence of more than one type of urinary incontinence represents the greatest burden of depression as compared with individuals who have particular type of urinary incontinence only. And there have been also the relationship between urinary incontinence and mental health outcomes. It's quite unclear. So for instance, anxiety may trigger the incontinent episodes, and conversely, the whole social stigmatization associated with urgency and with incontinence may confer feelings of anxiety. So individuals with urinary incontinence may develop depression due to also their decreased social functioning, and they may be reluctant to take part in different activities such as traveling far from home, socializing, and of course sexual life is one of the factors here. What about so this psychogenic bladder dysfunction that starts with altered brain activity under the stress conditions that may lead to increased urinary frequency, and that may easily continue with symptoms of urinary overactive bladder or interstitial cystitis. And you might observe also this sort of a vicious circle where patients with urgency, nocturia, and pain, they are sleep deprived, they stand up very often at night to urinate. Then at the day they are feeling a lot of fatigue, and deprivation of sleep also goes along with cognitive dysfunction and increased risk of anxiety and depression. That would have an impact on other areas of functioning that also includes sexual, and it also adds more to all the feelings of stress and anxiety and can exacerbate the urological symptoms. But for clinical practitioners, it's very important that if you don't cut this vicious circle, this will be going more and more and more severe. Now, a step a little bit inside the neurochemistry. So importantly, many psychotropic medications that are used in treatment of depression and anxiety or insomnia, for instance, they have also peripheral and central effects, such as anticholinergics, for instance, and neurotransmitters such as serotonin, gamma-aminobutyric acid, or acetylcholine are all involved not only in the pathophysiology of urinary symptoms, but also in mental health issues. And as you can see also, some of these drugs might be used to bring at least a short relief, like GABA receptor agonists, like Zolpidem and diazepam. They might be related to increased bladder capacity or prolonged mid-nutrition intervals, at least what was found very clearly in animal studies. And anticholinergic medications are very widely known in urology, and they are also present in psychotropic drugs. How about links to sexuality? We have this software of sexual response cycle on the central level, on the periphery, and you could see that cholinergic stimulation, serotonergic stimulation, noradrenergic stimulation are very important players that might be either stimulating or inhibiting factors. And cholinergic stimulation is quite important for increasing the blood flow into genitals. So giving anticholinergic might be related to decreased genital response as well, which might be the case in your patients. So serotonin is thought to be involved in the central peripheral control of micturition, and it has been shown repeatedly that central serotonergic transmission may inhibit the micturition, at least in rodents. And we did this research from clinical trials or clinical practices showing that psychiatric history and current use of especially more than 2 psychotropic medication was associated with increased severity of at least overactive bladder syndromes. Anxiety was found an important player, at least in internet surveys, but not depression here as predictive for more bothersome symptoms, which is actually quite predictable because anxiety may increase the urgency, as been already said. But the history of depression, also current treatment with drugs as SSRIs, but also venlafaxine is associated with increased severity of stress incontinence. This is interesting, especially with venlafaxine, which is a selective reuptake inhibitor of both noradrenaline and serotonin, similarly to duloxetine. But the key thing might be that duloxetine, which is often given, especially in urology, in lower doses, would act mainly via the noradrenergic pathway, while the venlafaxine, even the smaller doses, have more already have more serotonergic activity. So that might be the reason for that observation. But in fact, screening for psychiatric comorbidities would be recommended for all age group in patients of idiopathic LUTs. And what has been said so far, I think that both urologists or nurses in urological units should be this sort of first-line psychologist for the patients. It's very important to cover the psychological issues, and that's also what I asked the question, at what stage it's been done. I think you need this early, at least approach to talk to the patient and show that this is more complicated mechanism, and you have to take both into account, both the somatic and psychological issues. And you all know very well about this anatomical predisposing factor within the urinary system and the genitals. They are so close, and very often, especially like infections and inflammatories, may affect each other very easily. But LUTs have a clear impact on sexual well-being. And in case of bladder pain syndrome, that can very easily transfer into sexual pain, you will find the very high rates of dyspareunia in patients as compared with controls. There are almost 90% of patients that would meet women that will experience this sort of dyspareunia. And more than half of women with BPS would also avoid sexual intercourse with their partners because of these symptoms. How about overactive bladder? So here urgency is the main factor, and especially the fear of leaking during sexual activity in orgasm. Leaking during sexual activity has been reported by about 60% of women with urinary incontinence, and leaking during orgasm is very commonly related to detrussospasm, which happens during experience of orgasm. My clinical experience also is a bit deeper with patients with multiple sclerosis. I've been working for many years at the Institute of Psychiatry and Urology, and clearly in this patient, the neurogenic LUTs are very, very important issues, and according to studies, they are also very clearly associated with sexual dysfunction. So you should always take this into account. I'm sure that many of your patients are from this group of midlife women, which are and especially high risk of both urinary and sexual complaints. And the hormonal factor is another risk factor. So the perimenopause is the time when rates of FSD and urological dysfunction are growing. But the important statistic is that also almost 90% of women were reporting that the sexual health was an important issue for them, but only very, very few of them would discuss sexual problems with their clinical practitioners. So that's also, it shows that it's so much important that as clinicians you will be proactive with asking questions about sexual issues, about mental burden of the urological condition as well. Sexual and mental health consequences are huge, so it includes sexual abstinence at all, or sexual desire problem, orgasmic dysfunction, not only because of the direct influence of symptoms, but all the social cycle of the biopsychosocial interactions. And depression and anxiety, of course, they are key players, because both pain, anxiety, or depression, they are just sex killers for the patients. And even if you have huge sexual drive, you have partner you really admire and desire, and you have appropriate sexual stimuli, if at the same time you are feeling the fear, incontinence, coital urgency, you are getting shamed, embarrassed, and then you will feel less sexual arousal. That might be also combined with drugs, and altogether it turns the tipping point into sexual avoidance, not sexual motivation. So that's what you have to keep in mind as well. What about sexual relationships? So urinary incontinence was commonly related with shame, with avoidance, but looking partners of females with urinary incontinence, it's shown that about 40% of these partners were even unaware of the presence of coital incontinence. So especially when it's not very severe, sexual partners even don't realize that. And for those who are aware, also the majority do not consider this as so much important. So it's important for a psychoeducation of female patients with urgency incontinence, urinary incontinence. You already know this treatment guidelines of overactive bladder very well, but looking deeper into sexual influence, there's quite robust evidence that pelvic floor muscle training, oral medication for OAB also improved female sexual dysfunction. And beta agonists such as mirabegron might be also related with slightly lower risk of sexual dysfunction, because they bring less of mucosal dryness or arousal dysfunction, and some approaching good results for neuromodulation, and Botox still needed, more evidence is needed. In BPS, there is the improvement on sexual health is very strongly related to the relief of pain. If you don't have pain, you don't get so much sexual inhibition. That's quite obvious. And there are also primarily findings that treatments like intravesical therapies that have been taught so much about today, substances like hyaluronic acid and also other solutions might be beneficial for sexual health as well. So it's good to investigate it deeper, and I think we will see more evidence in a couple of years. With patients with neurogenic incontinence, such as mentioned patients with multiple sclerosis, for instance, many behavioral interventions should be implemented, such as already mentioned, limitation of fluids, alcohol, coffee, etc., but not to decrease the whole quality of life. So just check whether it works or not, but don't say, okay, you cannot ever drink this amount of fluid, forget about coffee, but about sipping wine with your beloved one in the evening. So it's not going to work this way. It's more about timing. It's more about checking what works and what doesn't work. You would not find a clear evidence in the literature towards only one particular intervention, like what will happen if I will ask my patient not to drink coffee anymore. You won't find evidence that it will heal sexually. You just have to be clever in that and try to experiment and to experience what works for the particular patient. In case of more severe cases of incontinence, surely catheterization in women would work because it doesn't also disturb penetrative sex so much. And in case of males, of course, it would. So urethral contraction that was already mentioned by Mikkel could work, not accepted by every male, but still can work and also can bring some benefit also to keeping longer erections as well. And there are psychotropic drugs. They are so widely used in patients with LUTs. May have many undesirable effects on LUT function as well, such as urinary retention, but usually with larger doses. I don't know how you find it in your practice, but usually it's not, especially the urinary retention, it's not so often. But some of them may have desirable effects. For instance, the duloxetine already mentioned that is quite good evidence as a treatment of stress urinary incontinence, and maybe potentially beneficial for overactive bladder. Desipramine is an older drug that has been forgot by many clinicians, but may also have some role in overactive bladder. But in fact, many psychotropic medication, including tricyclic antidepressants such as amitriptyline or imipramine, and also some antipsychotics, and especially first-generation antipsychotics, will display significant anticholinergic activity. So it might be used not only for therapeutic purposes, but you also keep in mind this side effects, especially on sexual arousal. Smaller doses of SSRIs usually don't interfere so much with cholinergic or noradrenergic pathways. However, this specific class of antidepressants that has been so widely used has been reported also to trigger a urinary hesitancy. Probably it comes by the central facilitation of the storage pathway. And on the other hand, unfortunately, psychotropic medications are the major sex killers, and we know this from our practice. As you could see in this table, all the red spots and dark yellow spots are the real sexual killers. So the majority of antidepressants will affect sexual life very negatively. And some of them, such as so the major mechanism besides will be the agonism towards serotonergic 2 and 3 receptors, while the agonism towards 5-HT1A might bring lower risk of sexual dysfunction, what you could find, for instance, for vortioxetine. That is not typical SSRI, but more serotonergic modulator. And other drugs as agomelatine working through melatonergic mechanism, or bupropion, which is selective reuptake inhibitor of dopamine, and noradrenaline doesn't bring these harmful effects on the sexual response cycle. In case of antipsychotics, the major mechanisms involved are dopaminergic antagonism that is non-selective and may bring may decrease sexual motivation, sexual desire, and sexual pleasure. On the other hand, the anticholinergic mechanism, especially for the first generation drugs, and all the possible hormonal influences, and also cardiometabolic complication of new generation, second generation antipsychotic is something to be kept in mind, because they are not immediate sexual killers, but they are long-going sexual killers, because after 6 months of treatment, the patient might be also 50 kilograms heavier, and with all the somatic burden of the process. So this should be taken into account in the practice. Mood stabilizers, anti-epileptic are not so much harmful for sexual function, but also not so often used in urological practice, so I'm not going to concentrate on them. It's time to finalize. So my take-home message is that mental and sexual health should be routinely addressed in patients with dysfunctional urinary conditions. And as been said, I would recommend you to be also the first-line psychosexologist for your patients, to follow this implicit model principles of permission, some limited information is extremely valuable for patient being assessed for urinary conditions. We have to understand the whole complexity, and the teamwork it's a good practice. These days, when we are so much specialized in medicine, we cannot be specialists for everything. We have to work in specialized teams. So please build your own networks of specialists, and consider also the sexual side effects when you consider using psychopharmacotherapy. And mention, last but not the least, sexuality should occupy the space it really deserves within all the treatment and rehabilitation program, also of urological and psychiatric disorders. So this is the teamwork, and if you want to work as a team, you can consider visiting the Vienna in February, so it will be a very nice occasion to meet specialists from different fields, but or oriented on sexual health and sexual life and sexual pleasure. Thank you very much for your attention.
Thank you, Michael. Any questions from the audience? I have a question for both of you, so Mikkel and Michael. What I've understood from your lecture is that the pre-treatment, I mean, especially for radiotherapy, sexual dysfunction and psychological disturbances are very, very underestimated. So the message coming from your lecture is that we need to better understand what is the situation before the treatment. So can you comment, Mikkel and Michael?
Oh, yeah. So should I start? Yeah, definitely. The urological problem doesn't appear in the desert, yes? So it appeared in a person that has certain history, both mental health history, relationship history, sexual life history, and it's quite common that patient will complain about certain condition they have when it is very much related with other symptoms. But in patients, especially with functional symptoms from different organs, including urological system, I think if you don't take into account this factor, you get very limited information. Probably you also don't know which way to follow clinically. I see it very often in patients with sexual pain, especially. They very often come in a long-standing relationship when they are dealing with pain alone for a couple of years, then with some like first-line specialists for a couple of years. And when they finally come to sexual health specialists, they are so much traumatized by the condition, and there's so much complication that already happened in their sexual life that sometimes I even see that it is not possible to solve within this particular relationship. So these relationships very often just break down, and they start solving the problem properly, but in the next relationship. So also this part of trauma and other effects should be taken into account. But definitely it's a completely different problem for a patient that has a very high sexual desire, very happy and fulfilling sexual life, and now the urological complaints make it just destroys that, and completely different in patients who are always wanting to have good sex but never have it because of maybe some psychological issues and other sort of, so sexual history is relevant.
Mikkel.
Yeah, I agree completely, and I just want to add that we don't have to know how to solve all of this. Just I want to underline, we have to have good friends that we can refer the patients to. We just have to acknowledge these problems and discover them and kind of open the patient's eyes to them. To answer the question from a different perspective, I think it's very difficult to talk to patients in depth about sexual dysfunction in practice, because it's radiation therapy typically, or surgery, whatever it is, for cancer. So the patients have anxiety about the cancer and they get a lot of information. But if we're able to talk to them about it, sometimes the patients will have different choices, but at least they will know that the side effect and the sexual dysfunction that they suffer is a consequence of a cancer treatment when it happens, and instead of it being something they're surprised about and kind of taken aback at. And it also gives the possibility for the partner to be informed up front, so that the partner can be more involved. So I think we can do some good things about talking about it, and again also before treatment involving the partner.
Other questions? So enjoy. Yeah, please. Copy coming here.
One remark to you also, Mikkel. We don't need to always to go into sex because they don't want it. But one of the side effects of the majority of the medication is the anticholinergic effect. It means dry mouth. Think to yourself how it is to kiss with a dry mouth. Where all sexuality and intimacy started, hugging and kissing. Yeah, but then you will have antidiuretic effect and you will need to run to the toilet for these patients. So try just to think about those simple aspects that you can even emphasize for the patient and dry the mouth to get the kisses. It's just basic things that are not measured because it's not sexual function. And remember that it's about also not only sexual function, it's also in a couple about the intimacy that a lot of time disappear in a case of pain, in case of cancer, in case of chronic diseases.
Thank you for the remark.
So welcome back. We will start the last part of the day now. And we're going to hear from past president of the ESSM, Kobe Reisman, who's going to be talking to us about responding to the needs and expectations of patients with erectile dysfunction, specifically on patients' perception on sildenafil or dispersible film. So Kobe, please.
Thank you, Mikkel. Thank you for the diehards who are still here to talk all the really things that matter, sex. Till now we were talking about related to sex, but now we will talk really about sexuality. I don't have any disclosure for this presentation, so what I will talk to you, try to understand the patient with ED, how prevalent it is. We will talk about the official pathway for treating the patient and manage the patient, and then their data that we have on the oral dispensable film with sildenafil, and what to do when sildenafil or any other PDE5 inhibitors doesn't work. Okay, so what is good erection? Someone of you have an idea? Everyone is silent. Okay, I expected that you will be silent. So good erection need to know what to expect. Okay, it's predictable that it will always come ready when you need it. And a lot of guys think I taken Viagra and they look there and nothing happened. Of course not, because you need desire and stimulation, but they expect that it come by like it is, have a good quality and last for the needed duration. And even then, go away when they need it. It's not appropriate to have an erection while you are walking on the beach or in the swimming pool, so they don't want to have it on that moment. And notice when the moment is coming. But what is erectile dysfunction is defined actually as a failure to achieve or to maintain a rigid penile erection, but pay attention. The most important part is satisfaction. It's all about satisfaction. So it's not only the rigidity measurement, but satisfactory of the act. And ED is not a disease as a symptom. For the majority of cases, there is a physical or psychological or both of them condition underlying the cause of the ED. And that's why we need to think what we can change or able to change. And we all accepted that PDE5 inhibitor is the first-line therapy in erectile dysfunction, and there is enough evidence for that. But how often ED appear? Actually, in increasing with age. And when you are 18 or 20, there are already 5% of the guys with ED, and it increased to 70% when you are in an older age, and I'm talking about 65 plus. So it's high prevalent condition, and a lot of men suffer from it. And what we also know, that the majority of them are not the severe ED. These are the moderate, and PDE5 inhibitors can work very well. But we need to realize that ED have tremendous impact on quality of life, and not only on the quality of life in general, it have an impact on physical and emotional satisfaction, and it have an impact of happiness. And unfortunately, majority of the people wait very long till they come to you or to us with this problem. So they suffer for a long period of time before they jump to our office and say, I have a problem, and admit it. And you heard today on a lot of other conditions will influence sexuality and certainly also ED. But in the early 60s, each improvement was already good. And later they wanted successful erection, and nowadays, majority of the guys who are coming to our office want normal sex life. What is normal sex life? How you define it for each person is different. But the majority of them expect that it will be very nice and firm erection when they need. And the ideal ED treatment should be effective, very rapid in onset, safe, without side effects, cheap, no effect on desire, discreet, spontaneous, unaffected by food and drink, and accepted by the partner. Do we have such a thing? I removed the picture, sorry, because we don't, where it is, it disappeared, the picture, sorry. But we don't have the ideal treatment. People need to do something for it. There is sometimes side effects. It costs, because majority of the countries, all the treatment are not reimbursed by the health insurance, so we don't have the ideal treatment. But we have, luckily, good treatment for ED. And remember that when you treat a patient or prescribe a PDE5 inhibitor, don't do it like you prescribe antibiotics. We have to hear today about all kinds of treatment, urine tract infections, etc. If you don't instruct the patient very well and they know what to expect, it will not work. No matter what, you can have a perfect penile prosthesis operation. If it's not fulfilled the expectation of the patient or the couple, it will still be a failure. So expectation management is very important, and talking about satisfaction. It's not only about rigid direction. Our doctor decide what to do. It depends on a lot of things. First of all, the treatment need to be effective, need to be safe, need to be tolerable, and for good duration. And we know that for the majority of the treatments of ED, they are very well effective and tolerate. But doctors want to have an experience. They want to rely about it and good reputation. For the blue pill, there is not always good reputation. People are ashamed that they have all kind of PDE5 inhibitors. But it's also depend on your idea of norms and value. And it's also depend on the norms and value and expectation of our patients. And not each ED patient can get any PDE5 inhibitors because there are some with contraindication and there are some failures that not respond or drop out. And the numbers of dropouts are tremendous, actually, even if the medication is effective, and I'll explain to you in a moment. But the patient and the physician look more or less for the same things, but there is difference. While the patient wants our direction, no side effects, and works each time, restores self-confidence, they want it also to be easy to use and quickly and faster in appearance. While the doctors want that it will be effective, it will improve erection, and we measure improvement. We not always measure with our studies our direction, but they want to have a patient satisfaction and spontaneity. That's what doctors want. But the reality is a little bit different than the studies that published with the phase 3 of all the PDE5 inhibitors. The reality is that between 30 to 40% of them are so-called failures. These are not real failures, but they come and they say that it's not working. And most of it is our fault as doctors, that we don't give them the right instruction and the right information, because 50% of them will not be failures. Despite that, 4% a month stop with taking the prescription, mainly the young ones. And you ask yourself why it's happening actually. And actually it's not only because of the effectiveness, is the expectation. And that's what I'm saying from the beginning, ask the patient what they need and what they want, and what they expect that it will work. And other reasons is that the partner is not involved. And if the partner is not involved, the patient can get a problem. Can you imagine what happened to a guy that have his tablets or film or whatsoever in his pocket or in the bathroom in a drawer, and his partner found the tablets? They didn't have sex for a few months because he had erectile dysfunction. What the partner will think about it? I can tell you, it's immediately in hell, because she will say, in case that they are heterosexual, he is a mistress. And try to convince that it's not true. It means that there is disagreement in the couple, fights, forget the sex. So try to involve the partner. There is sometimes lack in efficacy, and there are sometimes side effects. So we need to take all those things into account. And nowadays, the patients are the drivers of the car. They decide what they want. And it's okay that they decide, because we're talking about quality of life. We are not talking about curing cancer, taking away the stone as a urologist. We're talking about sexual dysfunction and sexual problems experienced by people totally different from each other. And they are switching a lot between them. They're looking to the ideal solutions, no side effects, what work faster, and how it's go. So what the guidelines say to us, let's look at the pathway of management. And if we looking at the European Association of Urology guidelines, they say very clearly that when we diagnose ED, we need to look on curable condition. Can we change something that caused the ED? Think about diabetes, hypertension, etc. We need to change lifestyle, and we need to provide education. Let's examine two of these aspects. They are right in the guidelines. I can tell you that lifestyle, we all know that we need to stop smoking, reduce alcohol, weight loss, certainly if we have physical obesity, and physical activities. I can tell you that the only evidence clearly that we have are on weight loss and physical activity. Because if you lose weight, you will improve your testosterone. And I'm not going into details of all the studies, I just show you one of the graphs. And if you do physical activity, at least for 6 months, and regular activity, and not once a week, but 3 to 5, and we don't have EDL program, you will improve the IAF. Look at that study, and the meta-analysis show us, I cannot use the laser, unfortunately, that you see the green spot, improve the IAF erectile function at least in 4 points. So it's significant, clinical meaningful. So stimulate your patients to adopt healthy lifestyle. But don't tell them only do lifestyle, because it will take at least 6 months to achieve these results. And they want the results here and now, but stimulated. What about other exercise that they can do? Pelvic floor. My previous speakers talk about pelvic floor, so remember that the pelvic floor is something that connected to our sexual activity. And if they control the pelvic floor better, they will also improve erectile function. You see the IAF changes. Why it is? Because muscles of the pelvic floor, the bulbocavernosus and the ischiocavernosus, are directly connected to our sexual function, to erectile function and premature ejaculation. And if they have good controlled pelvic floor, they will improve those functions, just to know. And don't forget to give the patient education and information, because majority of them are not getting medication from the doctors. They don't trust very well the doctors. They do it through internet and all kind of things. And some of the medication they take from the internet, not some, more than 80% of them are fake. And if you ever saw how Camagra is produced in India, you will never want to take it. I can tell you, I saw the factory. So be aware of that, okay? We need to improve our work and our contact with our patients. Give them trust, give them empathy, not just prescribing and go away. And remember, not only the instruction, do them follow up, adjust the doses, and discuss it with them. What to do with the doses? If you look at guidelines, there is no clear cut. You can do 2 things. Or you do top down, from you start 100 milligram, go to 25, or you go slowly up. I'm preferring the top down. Why? Because if the patient will not be successful with 50 milligram and you need to convince him to take the 100 milligram, he don't have a lot of confidence. And as you know, mindset is the most important sex organ, your mind. And if they have more trust, they are more relaxed. If they are more relaxed, the adrenaline is low, the penis will work much better, because adrenaline and penis are not good friends of each other. So give them trust, okay? And that's my recommendation. Start up, it will work much better. Then look what's happened with all the other parts. This is a little bit changed, I see in the presentation. Then you give PD5 inhibitors. And I told you they stop PD5 inhibitors a lot of times because of not partner involvement, lack of efficacy, and they are not suitable for them. And in Italy, they made a consensus according to the Delphi process. When you prescribe the patients, what you need to look at: efficacy according to rigidity, the opinion of the partner, and the individual tolerability. Fast enough, no side effects. These are very important issues that are done. When we look on all PD5 inhibitors, sildenafil, vardenafil, tadalafil, and avalnafil, the ones who are available in Europe, you can see that most of them working very comparable. The success percentage, if you look at SEP2 or SEP3 or IAF improvement, are somewhere between the 70 and the 80%. And that's true. That's also true in phase 4 and in clinical experience. But what we need to take into account is how fast they are working, and actually all three of them more or less the same when they are in tablet. You see that the tadalafil take more time but stays longer, and take into account the side effects. And the side effects are connected to the sensitivity to the other PDE receptors. So you can see that for sildenafil, the PDE1 is more prevalent than PDE6. What's happened? The blue vision and the heart rate, or the red face, is more prevalent than, for example, the avanafil. And if you look at the tadalafil, more muscle pain. So our complaints are not out of the blue, so you can adapt it. But now we have another player in the market. And the player is not different in substance. It's sildenafil, but it's the ODF formulation. You heard already a few words about it. And there is some advantages for this formulation. Why? That's what I will try to explain to you, okay? Is reaching some concentration in the blood much faster than the tablet form, because there is no first pass effect through the liver. There is no digestion in the stomach they need to take care. And even if it's not completely true for the experience, I can tell you I have patients that swear that it's working very fast and very convenient. This is the, let's say, pharmacokinetic of it. What else? As I told you, there is faster drug bioavailability, and it provides onset of action, and it doesn't matter where they put it. Under the tongue, above the tongue, is very easy. Is it effective? In these studies, they compared the 100 milligram tablet form with the 75 milligram of the film. And as you can see, is effective, but more important, the patient are even more satisfied. And I told you, it's not only about the route direction, it's about the satisfaction of the patient. That's the most important, satisfaction. Sex is about pleasure. It's not only about orgasm, it's not about the duration, and it's not about the intensity. It's make you happy, and your partner too, because it's also important. And if we look on the side effects, the oral dispensable film have more or less the same side effects of the tablet, with two important differences. The intensity of the side effects, as you can see, is lower than with the tablet, and it resolves more faster. So it's not only about how often side effects are apparent, what you see in a lot of studies, it's also the duration of the side effect and how severe are the side effects. And in case of the ODF, it's shorter and less severe. So it's improved tolerability. They don't need to swallow with water, easy to carry, which found for many people very important, and they don't need to show the blue pill that everyone knows. So it's more secret, more in confidence, without any problem. And as I told you in the beginning, what the expectation of the doctors and the patient for the treatment, you can see that this form answers a few of the issues that the patient expects and a few of the questions that the doctor expects from the treatment. So it's a promising formulation. Now, let's look when PDE5 inhibitors doesn't work. And we see that. When they don't work, the guidelines say to us, assess and adjust the doses, look on the best treatment option, maybe try with higher doses, and if it's not, go to second-line therapy. I advise you always to look very careful before you go to the second line, because the second line is much more invasive. Injection, vacuum pump, etc. So first of all, pay very good attention for the comorbidity, even before starting of the treatment. Are there any comorbidities that we are able to improve or to control? Diabetes, hypertension, except of motivating for lifestyle. How to use. In the case of the ODF, you don't care about the meal, but with other tablets, you need to care about the meal and the alcohol, but always explain to the patient that they need desire and they need sexual stimulation. And in case of the desire, and if they don't have good desire, think very well about hypogonadism, how it stays with their testosterone. And as I said, psychological issue, expectation, performance anxiety, are there any traumas, and relationship. Relationship with good erection is still, bad relationship with good erection is still a bad relationship. And that will not improve the sexuality in a lot of time. It's not that the urologists need to deal with relationship, but there are people who can deal with relationship issues called relationships therapists, okay? What can be happened, and that's certainly improvement, is the HB1AC, A1C level. That will improve sometimes the erection. Testosterone will certainly improve desire. When you measure testosterone, look at the SHBG, as you heard from Giovanni, and think about lifestyle, reduce weight, physical exercise, okay? And it's clear that testosterone replacement therapy will improve effect of PDE5 inhibitors when there is hypogonadism, but it will not on the spot. It will take at least 6 to 12 weeks that you will see the effect. When patients said to me, yeah, I put the testosterone in 2 days, I thought I already noticed the difference. I'm not saying to him bullshit, but I know that this is placebo. Okay? Placebo appear 30%. So be aware to tell them to wait a little bit till there is an effect. And in complex cases, or if you know that there are difficult to treat population like diabetes and severe diabetes, think about a combination therapy, because you can combine daily PDE5 inhibitors, tadalafil, with, for example, sildenafil as needed. It's working very well. Or with other therapy, like with shockwave or antioxidant, there is evidence in the literature for it. Even from vacuum therapy, there is a literature. In case of BPH with alpha blocker, I know that in the instruction you are not allowed to combine alpha blocker with PDE5 inhibitors, but this is not for the highly selective alpha blockers. And other combination with metformin, folic acid didn't work very well, so don't do that. So what to do with the failure? I will explain to you very easy. Improve the pharmacotherapy or the lifestyle with stop smoking, physical exercise, don't use drugs, reduce weight. This is certainly evidence-based. Increase the PDE5 dose, give good instruction or different PDE5 of combination of PDE5, and the film is an excellent for the combination with the daily, okay? Or look at other medication if they are on SSRIs, if they are on antihypertensive, if they are using antipsychotic medication. Try to look to the one with less sexual side effects. We know that it's working as well. And involve the partner, and when there is problem, send them to couple therapy as needed. You all saw the slide about the ESSM school, when all those aspects are going much deeper, and we have the clitoris ultrasound course school before it. You heard it from Giovanni and from Mikel, but I want to, it's not in the slide, to here explain to you another one issue. You may know that we have also European certification examination as a mark of excellence to become a sexual medicine physician. You saw my title and of my colleague here, FACSM. I don't know if my title is here. Yes. FECSM, but they means Fellow of the European Community of Sexual Medicine. Under the umbrella of the European Union of Medical Specialists, we created the Multidisciplinary Joint Committee on Sexual Medicine. It's a group, is a board inside the medical specialist who compound from representatives from the European boards of urology, gynecology, psychiatry, dermatology, venereology, and did I forget? Endocrinology, and residents. And people who have knowledge, for example, participate at the ESSM school, work in their daily practice with sexual medicine patients, ED, pain, sexual pain, also gynecologists on female sexual dysfunction, are allowed to go to take this examination. This examination from last year is online, so you do it from home. Don't think it's easy, because when you go into with your computer to the online examination, we see your room. It's fun for us, but seriously, we see what you're doing during the examination is from home, and you can become a fellow of the European community, which is a mark of excellence. All the information about it is on the website of the major multidisciplinary joint committee, is mjcsm.org, so you can think about it, join the school, get formal education, and come to the European examination. Thank you so much.
Thank you, Kobi. I would like to invite all the speakers on the podium. So, any questions? So again, Kobi, I think that even from your talk, you emphasized the need of multidisciplinary approach, the need to involve the partner, the need to combine the different drugs. So, any further comments?
I will not say need. I will say is recommended, okay? Some of the patients come inside and they don't have a partner, and they say, "Doctor, I have a problem." And I say, "What is the problem?" "My Willie is not willing to cooperate with me." Okay, it's not working. And you ask the question, and you give the instruction, and you listen very careful, and they go on with the prescription. And what I recommend, think very well what you prescribe to them. What are their needs, adapted to the patient? Do individualized medicine. Nowadays, we have the tendency to go according to guidelines. Guidelines are good, but it's only direction. Be personal with your patient, because at the end of the day, what all of us wanting is happy patients. You have happy patients, you have good reputation. If you get good reputation, you will have more patients, you will have more money, and you will drive a better car, okay? Or whatsoever. So what I'm saying is, be a good doctor for your patient, because at the end of the road is for you. And because our life is so complicated and no one can know everything, we need to work together. And to emphasize pelvic floor, gynecologists, psychiatrists, not just prescribe SSRI, look the one with less sexual dysfunction and side effects. So if you don't know him, Michal is here. Send him an email. Phone him if you are working together and know in Poland. So each one of us have create a network of people that you can trust, work together, and working together is more fun, like with sex. You can masturbate, but you have sex with someone else is better. Also, brain research show it to us. So if you work together, you will enjoy much more your work.
Another issue that I want you can comment. You mentioned the possible role of, nutraceutical products. There are some data related to vitamin D3, especially also for endothelial dysfunction and so on. Can you comment on the role of vitamin D3 in erectile dysfunction?
Let's say there is huge discussion about the role of vitamin D in erectile dysfunction. We know that vitamin D is important, okay? What is the exact role we don't understand yet? And there is discussion. Is that clear cut? No. But whenever you can combine those modalities, why not? If there is any direction, people go to the pharmacist nowadays and they spend thousands of euros on all kind of things that no one have checked, okay? The Mercedes dealers say that the new model of Mercedes is the best car ever. They did randomized trial? No, they can say whatever they want. Same go for the pharmacist, but we have some evidence that vitamin D can improve, like L-arginine can improve. So there are a combination of things that can work even better. Why not to try them? So I'm a supportive of that.
Thank you, Kobe. I think that we have very, very great morning. What I want to know nowadays from each speaker is the final take-home message that we need to bring home. And for sure, all the SSM speakers will be available for all of you. So if you have any problems, you can contact us, as Kobe said. So please, Mikkel.
I think for me and maybe for the whole session today in general, the main idea is to look at the whole person and the whole person's life, including the partner, and not to focus too specifically on one aspect.
Michael?
For me as a psychiatrist, it's so much important to underline that brain is the most important sexual organ. It's not the penis, it's not the vagina, it's brain, where it starts and where it starts with desire and where it ends with orgasm. So in the whole psychosomatic cycle, you can never achieve any goal without mentioning mind of a patient, brain, and understand, maybe not going very deep into the biochemistry, but to understand if you don't take into account patient's feelings, patient's emotions, and the whole psychosomatic cycle, you don't understand patient at all. So take the brain into account.
Anna?
Strongly agree to see a patient as a whole, including whole context of his life, of his partner, of her partner, and I strongly emphasize to see patient clearly, without prejudice, without gender bias, without to take them seriously. And when it comes to chronic illnesses, chronic conditions, it's whatever it takes. We should try everything to bring them comfort and health.
Wojciech?
So I would like to tell that the pelvic chronic pain, the pain syndrome is a real deal, that it's much more common than we previously thought. Those patients really suffer and they need some multidisciplinary team to cure them or even alleviate the symptoms. And one more comment regarding the vitamin D. As I run the endourology unit in my hospital, taking the vitamin D in big dosages without any prescriptive dosing or thinking about it can lead to other urological problems that can give you a nice scar because of the operation, which are urolithiasis, of course. So we had some patients, especially children, especially in COVID-19 period, when it was believed that vitamin D can be curative for the COVID. Even maybe only in Poland there was that saying between the patients, but it was. And we had maybe not the wave of the patient, but a lot of patients with really advanced urolithiasis because of vitamin D abuse, I would say. Yeah.
Kobe?
But as you know, each extreme is the... two messages. When the patient tell you that they have pain, and even if we don't understand it, they have pain, believe them. That will change your relationship with the patient. And the second is the message that I say to everyone, connecting to what Michal said, the penis is the antennas of the heart. It means that physical and emotional. We say that emotions are in the heart, so when you feel comfortable and good and have a contact with your partner, it will be much nicer, also for the penis and also for the sex. And penis can a sign of cardiovascular risk factors, so pay attention to it very well.
Another final issue, oral dispersible film is available in Poland, it's not available in Denmark, if I'm not wrong. So what is your feeling with this kind of drug?
we do not have precise data showing how much of this particular active component is being secreted into urine, so it's difficult to say it, let's say, objectively, but let's say the experience, I can tell from experience and from some touch that it may work if it's only the placebo effect that was mentioned before, if it really works. I like it, I give it, it gives the patient some option, which is, for example, in Poland, as the Yalu is not reimbursed, it's much cheaper, so maybe, but for sure for longer periods of time, it's not like one dosage will solve the problem, and in the dosing which is proposed by the manufacturer.
Anna?
So I'm sorry, I think that was an answer to hyaluronic acid.
Yeah,
Yes.
no, I was mentioned on oral dispersible film.
PD5
I mean,
inhibitors.
the sildenafil.
Oh, sorry. I misheard
No.
Yes, I really love it. I use it in my patient as well. So, believe me, Anna, let's
fine.
Let's have a function for it. So, yes, I love it. I give it to my patients, and they love it as well. And in Poland, it's not reimbursed as well, but the price is affordable. So those people just buy them.
Well, if they only can afford it, this is the kind of treatment that reaches the level of ideal that we are trying to achieve.
Michael?
Yeah, I believe I use it quite a lot in practice, and I found this is a very high quality formulation of sildenafil. I don't know, we don't have the randomized trial to prove it is better than the tablets or other, so both formulation for tablets, but you also have to hear the patient preference, and what I found that patients perceive it as well tolerated and quite convenient. So if you follow the patient's preference, it's very well welcomed by in clinical practice by the patients.
Yeah, and just to add my perspective on that, we don't have the oral dispersible film in Denmark, but I do give my patients the choice between the PD5 inhibitors that we have, and I like to prescribe more than one PD5 inhibitor, and they can try different ones and really go by their preference.
No, for sure. Also, along with the SSM, we are working in order to provide more evidence on the use of oral dispersible film. But I wanted to ask you the final questions. Kobe emphasized a great problem. So do you prefer to start top and down of the dosage or down and top? I completely agree with Kobe, but I would like to know your idea.
I will answer the two questions. The previous one, we don't have randomized trial between all the formulation. We have limited data, but from clinical experience, and we don't have the film in Netherlands, but guys can sometimes arrange it, and now they're putting pressure on me to get them these films. Why? Because I'm not talking about young and old. I'm talking about the single. Okay, the single guy don't want to run around with a tablet. He don't know what he will have the date that will have the opportunity, and this is for them convenience. If it's placebo or not placebo, I don't know, but some of them report that it's working faster. I'm not going against their experience because, as I told you, mind is stronger than body. So this is a good opportunity, and we need to offer them if it's available. So put the pressure in your countries or the distributors to bring it. Anyway, concerning your second question, I always start top down, okay? Because it's easier to convince the patient. If they will have some side effects, you can go down. If they have convinced that it's working very well, it's very easy to say, you know what, take half of it. It will save you money. In case of the tablet, for example, it will save you money. They can split it in two. And it's easy to do, and confidence is all the issue in performance anxiety, is all the issue in tension. And as I told you, when you the guys start to think, will I succeed, will I not succeed? For them, is performance with gun to the head. No. Except of the surgeons, majority of the people cannot perform with gun to the head. That's how it is. So, and then the adrenaline go up, as I say, penis say, bye-bye, I'm not there. And then they start to go into the circle of performance anxiety. So go up, go down, it's excellent. And as I told you, sometimes in difficult to treat patients, I even combine medications, so they get higher doses of the tablet of combination of PD-5 inhibitors. It's safe, it's not a problem. Early days, we had the people who walk around with nitroglycerin. Nowadays, a guy who has a heart attack, go to the emergency room, immediately took the catheter angiography, get a stent or bypass, and after 6 weeks, they are back to work, so they can also have sex.
I think you got the crucial point. Michele, you can address, maybe you can add some few words. So especially in people with psychogenic ED, if we start with very low dosage, and obviously with performance anxiety, the dosage cannot work, it creates a vicious cycle, very difficult to treat. So Michele.
Well, I don't have a simple answer for that, but I'm a psychiatrist, so I like to make things complicated, you know. Yes. So it's also because I often see patients that have been previously treated for erectile dysfunction. They are using very high doses, and my task is to taper the dose down and to convince them that maybe they don't even have to take it, for some of them, of course. But truly, it all depends on the patients, because if the anxiety is really high, then whatever dose you take, it won't work, because anxiety is always stronger. It's a fight or flight mechanism. If you feel really in danger, you can have beautiful partner, you have 1,000 milligrams of sildenafil, and probably it won't work at all. And so it's always... There will be maybe more pain in the head. And also, yeah, sometimes patients are also complaining of more adverse effects if they take a bigger dose. So from the psychological point of view, for some patients, it would be good to start with a smaller dose, so they know, okay, it's just a very delicate medication and I'm not so very ill, so I have time to take, maybe later on I will take the higher dose. And if they start with lower dose, you can also start working with them more psychologically, and you can decrease the level of anxiety, and still then you can take the dose up, and it all starts working better. So from the view of a person who would address psychological issues from the very beginning, starting with a lower dose is also a good idea. But you are right, if it doesn't work, it doesn't make any sense to keep the patient on lower dose for months, but to go very fast to higher dose, of course. Yeah, that would be also efficient.
Michael?
Yeah, actually, I completely agree. I see a lot of very severe cases, and if it's organic, I start in the highest dose. But the ones I give a crutch for the presumed psychogenic, I actually give 25 milligrams. I would never do that to somebody I think is organic. So I agree completely. I also just want to say that giving this PD-5 inhibitor to the psychogenic cases can be a double-edged sword, because for some patients, it's going to increase anxiety. When they take the tablet, they think, wow, now I really need to be able to perform. And if they're not, that's going to increase anxiety. So it's not for everybody. We have to be mindful.
Anna?
Well, it really depends on the patient. It takes multidisciplinary approach along with our friends, psychiatrists, psychotherapists, to find the right solution. I strongly agree with starting with large dose, mostly to prevent that vicious cycle of performance anxiety. But as patients are individuals, they're not hive-minded, so there is no one treatment that would suit all of them.
And I totally agree. I normally start with the higher dosing, but in those patients with psychological problems, it's maybe not the best option, but normally from up to down.
Finally, we have your opinion regarding the hyaluronic acids. Can you give the last message? Who are the best candidate for the use of this kind of drug?
So in my humble opinion, those are women with recurrent infection. This is the main, the core patients for that.
Yes, I agree. Every chronic condition needs to be taken care of in a broad spectrum of activities, of interventions.
Kobe?
There is not a lot of risk to use it, the hyaluronic acid, and there is some benefit, and I explicitly say in the case of chronic bladder pain, chronic pelvic pain, overactive bladder, interstitial cystitis, etc., all the indications that are there, it's one of the modality that need to be combined with the other modality, because it's not, we don't know always one factor that causes it, so approach it for different approach and support the patient as best as possible.
Michael?
This is not my field, so I
Yeah,
cannot pass
but you
the
can
mic.
have an idea.
Yeah, well, from my perspective, I would add the psychological discussion from the early beginning, and probably also some behavioral part of it, and I would leave all the rest to the urologist.
So Mikkel, final, your opinion, final conclusion.
So my opinion, well, from the literature, the clearest indication is the recurrent urinary tract infections, and then you have to be careful and really follow if it's working or if it's not. For bladder pain syndrome, it's one of the early treatments we can give. Again, we got to be very mindful, is it working or should we move on to more invasive treatments? And then we actually try it also sometimes for OAB, which is an overactive bladder, which there is a little bit of evidence, and sometimes we see an effect. Again, follow the patients and see if they have effect, and do something else if it doesn't have. I think that's my key message with this.
Okay, I think we need to thank again IBSA for hosting us here in this fantastic place with a great dinner yesterday. I personally understood a lot today, so learned a lot. So I'd like also to thank all of you who are here. I don't know if you can give some final words.
Likewise, from myself and from the IBSA headquarters, I'd like to start thanking our esteemed speakers here. Of course, the two coming from Poland and the esteemed experts from ESSM as well. I'd like to thank all of our guests, some coming from Switzerland, some from the affiliates, KOL, scientific minds, and distributors alike. Thank you all for pushing the boundaries of science, for stimulating discussion, and realizing the multifactorial evidence, both from a physical and a mental, psychological standpoint, that these diseases carry with them, as we've seen today with these presentations. I hope you enjoyed the event. In my opinion, it was a great success and something we would like to promote and repeat in the future. Please follow along and participate with ESSM, IBSA, our individual and collaborative efforts in the future. Again, thank you for coming, and we'll see you and continue the discussion here outside and downstairs for the lunch reception. Thank you.